Good morning, dear guests. What do you think? Are we ready to start, or we just need to wait somebody else and then just start? Let's start. So, welcome on the second day of ICE meeting, and today we're going to discuss diabetes and its cardiovascular system and cardiovascular complications. The problem is very severe, and let's start with the first presenter, Anastasia Baranova. Please welcome. The impact of type 2 diabetes mellitus on outcomes in patients with acute decompensated heart failure.
Good morning, dear colleagues. I'd like to begin by thanking you all for coming today. Let's get started. The purpose of my talk is to illustrate the impact of type 2 diabetes on outcomes in patients with acute decompensated heart failure. So, first of all, I'd like to give you an overview about chronic heart failure. It is well known that chronic heart failure is a widespread condition, and chronic heart failure means, in general, that heart muscle cannot provide a normal perfusion of organs and tissues, or this maintaining requires overload of different compensatory mechanisms. And not surprisingly, that chronic heart failure decreases in quality of life, increases mortality, demand of hospitalization. So what does it mean, acute decompensated heart failure? That means sudden build-up of typical symptoms, for example, swelling on the leg with pulmonary edema, ascites, palpitation, and so on. And most severe cases occur in elderly patients with comorbidities. It is clear. And type 2 diabetes mellitus is one of the factors that worsens the prognosis of such patients. So in recent years, the progress in the treatment of type 2 diabetes has been made, and the management of chronic heart failure has also become more successful. So that's why our patients become older. Let's face to the epidemiology. So the prevalence of chronic heart failure in general population is about 1%. It's Russian population, first of all. And the prevalence of chronic heart failure increases in patients older than 70 years old. The frequency of death from all cases in patients hospitalized with acute decompensated heart failure is about 17% over 12 months, and frequency of readmissions of such patients is about 44%. The prevalence of diabetes in patients with chronic heart failure is about 12%, and prevalence rises in patients hospitalized with acute decompensated heart failure. So, I'd like to perform a retrospective cohort study of patients consecutively admitted to the City Clinical Hospital number 13 based on Nizhny Novgorod during 2 years. The register includes 735 consecutive admissions of patients with acute decompensated heart failure. We have our research to study the outcomes in patients hospitalized with acute decompensated heart failure. And the aim of study was to determine different predictors that can worsen the prognosis of such patients. And we tried to identify the prevalence of diabetes in patients hospitalized with acute decompensated heart failure, evaluate different characteristics of patients, determine the impact of type 2 diabetes mellitus on hospital mortality, and evaluate the significance of type 2 diabetes on outcomes in patients with acute decompensated heart failure for 18 months and 5 years. So, during this investigation, we use different statistical tests, and the data are interpreted on the basis standard deviation, median, quartile range. For comparing one group with another, we used students' t-test, Pearson chi-square test, Mann-Whitney test. For analysis of prognosis, we use Cox model. The data are presented using odds ratio, confidence interval, and the survival curves were designed by a Kaplan-Meier plot. So, criteria for inclusion. First of all, we analyzed the following clinical situation. stagnation in both circulation or acute left ventricular heart failure in patients with chronic heart failure. And patients with acute MI were not included in the register, and the median follow-up was 1,790 days. So let's turn to the clinical characteristics. So, you can see that only palpitation was different, and patients with diabetes had less such symptoms. What about comorbidity? It is found that patients with diabetes had more frequent arterial hypertension and more frequent obesity. This information was expected, but you can see that patients with diabetes had less atrial fibrillation and less chronic obstructive pulmonary disease. Such information was unexpected for us. And at first glance, the results do not fit into the previous evidence. These results contravene previous evidence about role of diabetes in the development of atrial fibrillation, for example. But this information can be explained by so patients without diabetes requires other aggravating factors for development of such severity chronic heart failure. What about laboratory? You can see that patients with diabetes had higher level of proteinuria, higher level of massive proteinuria, and high level of creatinine. Many of patients had oral hypoglycemic therapy. 1/3 received insulin. What about hospital mortality? As for hospital mortality, patients with diabetes had severe risk, and you can see that hospital mortality was higher more significantly than hospital mortality in patients without diabetes. And we identified the prognostic factors of hospital mortality associated with acute decompensated heart failure. And you can see that diabetes type 2 increased the risk of hospital mortality, but also other predictors can increase, first of all, ILT, high level of ILT, high level of creatinine, and low level of hemoglobin. What about survival? First of all, the following trend was revealed. Patients with type 2 diabetes often needed readmissions associated with acute decompensated heart failure, and the 18-month survival of patients with type 2 diabetes was also lower. And we identified prognostic factors for 18 months survival, and you can see that type 2 diabetes also had a higher risk. And other predictors, you can see low injection fraction, high level of ILT, low level of hemoglobin, high level of creatinine, and most of all, pulmonary hypertension had a role. What about 5 years survival? After 5 years, 65% died in the group with diabetes type 2, and 58% died in the group without diabetes, so survival curves differ significantly. And we identified prognostic factors of adverse outcome within 5 years in patients with acute decompensated heart failure, and you can see that type 2 diabetes kept the key role as a predictor, and presence of type 2 diabetes had a higher risk of mortality. But we identify different adverse prognostic factors, for example, age, high LT, low injection fraction, high creatinine, pulmonary hypertension, and anemia. You can see all cases of death after 5 years, and 52% of patients with diabetes died from progression of chronic heart failure. As for patients without diabetes, only 41% died from progression of chronic heart failure. So, and we can conclude that diabetes is an independent risk factor for adverse outcome. And the presence of diabetes is accompanied by increased demand for readmissions in patients with chronic heart failure and increased risk of death. So, diabetes type 2 is not a marker of severity of chronic heart failure. It is not a manifestation, but diabetes type 2 has impact on outcomes of such patients. The adverse impact of diabetes manifests itself mostly in the index hospitalization. And after then, this effect gradually decreases. You can see the odds ratio. And to sum up, more than half of death in the group of diabetes occurs as the result of progression of chronic heart failure. And diabetes can be marked frequent concomitant state in acute decompensated heart failure, more than 35 of cases. And diabetes increases demand of readmissions. It was trend. And diabetes is independent risk factor for death during the index hospitalization, first of all, and over the next 18 months and 5 years. Thank you for your attention.
Thank you very much for a brilliant presentation. Does anybody have a question? Okay. Maybe I will start with the questions. I have some. So first of all, I would like to say that the cohort of study is very impressive, lots of patients. But I would like to know...
we try to include all patients with acute decompensated heart failure in our hospital, all.
And I'd like to know about the lipid levels of all included patients except common cholesterol. And another question, does all the patients got statins and diazepam therapy before hospitalization?
So, thank you for your questions. First of all, about total cholesterol. We cannot find any evidence about higher level cholesterol as a risk factor. But we found some evidence that very low total cholesterol may be risk factor. And we tried to explain this information like patients with chronic heart failure, severe chronic heart failure. Sometimes such patients have liver insufficiency, maybe that, I don't know. But first of all, total cholesterol is independent risk for patients with ischemic heart disease mostly. Now we discussed chronic heart failure, not only due to ischemic heart disease, maybe due to dilated cardiomyopathy or other reasons, arterial hypertension without dyslipidemia, without severe dyslipidemia. So that's why about high level of total cholesterol, we cannot find something. We cannot evidence about adverse outcome due to dyslipidemia.
And the evidence about low cholesterol levels, is it your data or literature data?
If you read in your guidelines about management of chronic heart failure, you can find some information about statins therapy, and now new guidelines don't recommend frequent prescribing statins for patients with chronic heart failure, severe chronic heart failure, plus ischemic heart disease. So I suppose that this information is connected with some evidence about it.
But I guess all patients with diabetes mellitus should get therapy of statins and diazepam.
We discussed comorbid patients. Our patients had many diseases: diabetes, chronic heart failure, liver disease, chronic kidney disease, and we try to prescribe careful management for them. So that's why sometimes we should estimate advantages and disadvantages of our therapy. Imagine situation, your patient has higher level of statins, but liver insufficiency, it's problem.
No.
Next question, I forgot your next question.
Okay.
I guess I got the answer.
Yeah. First of all, thank you very much for your presentation. I think it's brilliant, both work and presentation. And also for our foreign friends, I would like to say that Anastasia comes from a very beautiful city in Russia. It's the first biggest city, and it's one of my absolute favorites. And your university you showed, I think it looks very much like European university of 18th century something. So. Your answer to the previous question gave me an idea of another question. Did you somehow, or maybe I missed it, but did you somehow differ the patients by groups depending on the cause of the acute heart failure? Like you said, it can be different diseases, and were there any differences?
Okay. we try to divide according to primary cause of chronic heart failure, but imagine that severe end stage of chronic heart failure is the end stage of chronic heart failure in general. And for example, chronic kidney disease is due to nephrosclerosis. It doesn't matter of primary cause, glomerulonephritis maybe, or diabetic nephropathy. And the end stage of chronic kidney disease, we can find only nephrosclerosis on biopsy. In severe chronic heart failure, we can find the similar situation, similar changes, dilatation, systolic dysfunction, severe plus diastolic dysfunction, and so on. So that's why we try to analyze the primary cause, but without any severe results, because all patients with severe chronic heart failure are similar.
Thank you. Most interesting.
Thanks.
And sorry, and I have asked one question. Спасибо. And did you have any difference in the deaths, number of deaths between the different diabetic treatment strategy in your patients?
Could you repeat, please?
Sorry?
Could you repeat, please, your question?
Did you have the difference in the number of deaths?
Deaths.
Yeah, depending on the different diabetes strategy, treatment strategy. Yeah.
Interesting question. I thought about it, but this study analyzed first of all outcomes on chronic heart failure. And we try to analyze treatment of diabetic, but these patients received different therapy, and during 5 years, their physician changed that therapy. If our study was about diabetic therapy or diabetes mostly, of course we try to advise similar therapy. For example, I prescribe for my patient insulin, and during 5 years I try to control this therapy. But imagine 5 years, maybe during index hospitalization, patient had diet or oral therapy, but during 5 years he may change on insulin and so on. So that's why we cannot analyze it. Thanks.
Thank you very much. Lots of questions, are very interesting subjects of discussion, but we need to continue our session. And I would like to invite here Ivan Pchelin, Clinical Correlates of Thromboddynamics in Men with Metabolic Syndrome, the Impact of Insulin Resistance. Please welcome.
Good morning, dear chairs, dear colleagues. First of all, I would like to thank the organizing committee for this opportunity to be here. I remember the first ICE meeting in Rotterdam, and it was difficult to believe that this is possible in Moscow, but you've done this great job, and I think that this is a real historical event, this ICE meeting in Russia. Today I would like to share with you some very pilot data on thromboddynamics in insulin-resistant patients with metabolic syndrome. This is my disclosure. So, hypercoagulation in patients with metabolic syndrome is very prevalent, and it results from dyslipidemia, insulin resistance, adipokines, LDL oxidation, hyperhomocysteine, and other factors. And the underlying mechanisms are increased expression of adhesion molecules, elevated levels of platelet microparticles, increased intraplatelet calcium, endothelial dysfunction, resistance to effects of nitric oxide, increased production of thromboxane A2, and others. Well, classical coagulation tests are not sensitive enough for hypercoagulation conditions, but there are some novel assays, and one of these is thrombodynamics test. This is a novel assay designed for in-depth investigation of spatial and temporal dynamics of blood coagulation, initiated by localized coagulation activator under conditions similar to the conditions of blood clotting in vivo. This test is performed in a thin layer of plasma using special camera with time-lapse microscopy, and it allows us to assess the lag time before clotting, their initial and average rates of clot growth, the size of clots, and what's very important also the spontaneous formation of clots that is normally not observed during the first 30 minutes. And in the present study, we tried to assess procoagulant factors and clinical correlates of thrombodynamics parameters in insulin-resistant and non-insulin-resistant men with metabolic syndrome. We investigated 79 male patients with metabolic syndrome diagnosed in accordance with IDF criteria. We didn't include patients with type 2 diabetes, history of ischemic heart disease, liver, kidney diseases, cancer, or patients receiving anticoagulant or antiaggregant medications. The main group consisted of 44 men with metabolic syndrome, including insulin resistance, and the control group consisted of 35 men with metabolic syndrome without insulin resistance. In addition to routine tests, we performed the thrombodynamics assay and measured serum levels of homocysteine, D-dimer, plasminogen activator inhibitor 1, leptin, and adiponectin. Insulin-resistant patients had higher levels of fasting glucose, insulin, HOMA-IR index, leptin, lower level of total testosterone, and there were no differences in terms of age, waist circumference, adiponectin, GFR, homocysteine, and most other laboratory parameters. When we checked for factors of hypercoagulation, we found that insulin-resistant patients had higher levels of plasminogen activator inhibitor 1, and also they had a higher density of the clot in the thermodynamics assay. More than 1/3 of patients in both groups had elevated level of homocysteine, and most patients had elevated level of plasminogen activator inhibitor, with the significant difference between their insulin-resistant and non-insulin resistant group. Interestingly, most patients in both groups had elevated rates of clot growth, I mean initial rate and average rate of clot growth. Most of them also had spontaneous formation of clots, and the increased clot density was less prevalent, but there was a significant difference between the insulin resistant and non-insulin resistant groups. So insulin resistant patients usually had increased clot density more often. When we checked for clinical correlates, we found that average rate of clot growth correlated positively with homocysteine level, but only in the insulin-resistant group, and there were no significant interconnections with age, body mass index, GFR, HbA1c, LDL, and most other laboratory parameters. We observed the same situation of about the initial rate of clot growth. Also, it correlated positively with the homocysteine level. And the clot density correlated positively with C-reactive protein and correlated negatively with serum levels of total cholesterol, LDL, triglycerides. And also, I have to mention that we didn't find any significant determinants for the thrombodynamics parameters in non-insulin resistant patients. So to sum up my short presentation, I would like to say these key points. They are that most men with metabolic syndrome have elevated initial and average rates of clot growth in thrombodynamics assay. Patients with insulin resistance have higher serum levels of plasminogen activator inhibitor 1 and higher clot density than non-insulin resistant patients with metabolic syndrome. Average and initial rates of clot growth correlate positively with serum homocysteine level in insulin resistant patients with metabolic syndrome, and clot density correlates positively with serum levels of C-reactive protein and correlates negatively with total cholesterol, LDL, and triglycerides in insulin-resistant patients with metabolic syndrome. Thank you for your attention, and I hope that once the ICE meeting will come to St. Petersburg as well.
Thank you very much. Any questions, audience? While the audience is thinking, I would like to ask a question. Does any patient got the intake of disaggregants or antiplatelet agents, or it was an exclusion criteria?
It was an exclusion criteria. We tried to investigate naive patients.
Thank you.
Ivan, thank you for your most interesting topic. I think insulin resistance is one of the most interesting things in endocrinology. So my question is probably a little bit naive, but as a clinical outcome of your interesting work, do you suggest that we should pay more attention to patients with who are not maybe even patients yet, who have the insulin resistance but not yet diabetes and are not very keen for any checkup at endocrinologist or cardiologist? So like, should we prescribe antiaggregants or something else earlier than we do now to prevent bad outcomes?
Thank you, Katerina. Well, I'm very fixed on the idea of personalized medicine. So any research I'm involved in, I try to think about some items that will help us to choose the right medication for right patients. So maybe we need such kind of novel assays to find the high risk groups and to start antiplatelet therapy earlier and so on.
Any other questions? Well, thank you, Ivan, very much.
And in next presentation, the effect of preoperative blood glucose control on postoperative values. Medea Amashukeli.
Good morning, dear colleagues. I'd like to start. Multiple observational retrospective studies and randomized control trials have showed the results that higher blood glucose levels during or after coronary artery bypass graft is an independent risk factor for mortality and morbidity in type 2 diabetes as well as non-diabetes patients. So this was the background while the Society of Thoracic Surgeons issued practice guidelines setting target level at less than 180 milligrams per deciliter, and the American Heart Association and American College of Cardiology revised the guidelines but did not change the target level, so the target is remains the same throughout the years. And the aim of our study was to identify the risk factors for post-operative hyperglycemia in patients in type 2 diabetes patients after CABG, so to be able to prevent them preoperatively. For this reason, 70 insulin-naive patients were included in the study. Among them were 51 males and 19 females, and they received continuous intravenous insulin infusion until the third post-operative day as recommended by the Portland protocol, and after that, after the third post-operative day, they were transferred to the ward, and the intravenous insulin was changed to subcutaneous multiple daily insulin injections using intermediate and fast-acting insulins. Now, to characterize the patients, we calculated the median and range of the values. So the median age of this patient was 62 years. HbA1c was 7.9. Median glucose values post-operatively was 153. Insulin dose they received to correct their glycemia was 32, and median weight was 92 kilograms. Now the analysis showed the strong and very significant correlation between preoperative HbA1c level and postoperative blood glucose values, as well as the correlation between HbA1c preoperatively and the daily insulin daily dose were highly correlated with each other. And the interesting fact is with a p-value less than 0.005. Interesting is that the correlation between patients' weight and insulin daily dose was significant, but not as strong and not as much as the correlation between HbA1c preoperatively and blood glucose values postoperatively. And you all know that we usually calculate the insulin daily dose based on patients' weight, but in this case, the analysis and the results of our study allows us to recommend that that good metabolic control is necessary in patients awaiting CABG, and the value of HbA1c should be considered to estimate the daily dose of insulin, not only the weight of the patient. Thank you very much.
Thank you. And questions? Mm-hmm.
Thank you for your interesting talk. I was just wondering, how many days or months or weeks were between the measurement post-operative and the HbA1c measurement of the patients?
HbA1c is measured about a week before operation, or just a couple days, and then the patients undergo operation, and the blood glucose values that I have here are about the 5th or 6th day post-operatively. So not in the intensive care unit. There they use continuous intravenous infusion, and then they are transferred to the subcutaneous insulin.
Okay, and then do you intend to measure the HbA1c measurements later on? Because, of course, if you measure them just before the surgery, it might be interesting to see them like maybe 5 or 6 weeks after surgery, how they have changed.
Yes, they may have been changed, but now the purpose of our study was to find out the preoperative risk factors of post-operative hyperglycemia, and the period after post-operation, the post-operative period is actually under our control more than under the patient's control. So it's probably there won't be worsening of HbA1c.
Thank you.
And yeah, we try to control those values strictly.
I'm sorry, now we don't have enough time for other questions. Thank you very much.
Okay, thank you.
And I would like to invite the next speaker, Ekaterina Ivannikova, and her presentation, Advanced Glycation and End Products, Fibroblast Growth Factors and the Development of Atherosclerosis in Patients with Diabetes.
Good morning, dear colleague. As you know, the hypoglycemia is the main demanding factor for activation of different mechanisms, including accumulation, a huge of advanced glycation end products, and what stimulate pathological acceleration of collagen synthesis and by fibroblasts and own growth factors. This process leads of restructuring of wall vessels. Advanced glycation end products increase intracellular glucose leads to the formation via the non-enzymatic glycosylation of intra and extracellular proteins. Non-enzymatic glycosylation is the result of the interaction of glucose with amino groups of proteins. The interaction of AGAs and their receptors results in the inflammation, coagulation, and vasoconstriction, and other pathological process and synthesis of a lot of markers, endothelial dysfunction. The aim of our study was investigate the level of AGAs and their receptors and fibroblast growth factors in patients with severity atherosclerosis, coronary artery disease, and diabetes mellitus. 143 patients were included in our study, and they split into two groups, with diabetes and without. All patients were of comparable age and body mass index, and the speed of the glomerular filtration didn't not differ statistically. CAD duration was around 15 years. And the patients with diabetes had more higher mass index of left ventricular myocardium. And here we saw that patients with diabetes had more and more multiple vessel stenosis. We in our study we included 38 patients with acute coronary syndrome and with no ST segment elevation. There was no relevant of difference between the groups, and the patients of acute coronary syndrome had 1.5 times more bigger level of basic fibroblast growth factors. And we know got some difference between levels of transformer growth factors of fibroblasts, beta 1. but we saw that we see that the level of transforming growth factors was higher at patients with diabetes. The same results we got about advanced glycation and products, but their range, their receptor was higher 2 times at patients with diabetes, and however, in at patients with acute coronary syndrome was higher. All the patients included to our study have been dissolved for 1 year, and the level of basic fibroblast growth factors was detected among the patients in 1 year after the treatment. Special attention we should be paid to the stable positive correlation of level beta FGF and mortality. The level of transforming growth factors was noted in the progression study over time among the patients in group 2 without diabetes. And the age level change was insignificant, and we detected decrease in receptor of advanced glycation, of receptor of age, and all patients with CAD. And at the conclusion, the study of age and their receptors and fibroblast growth factors may have prognostic value for determining the treatment of patients with diabetes and coronary heart disease. And this photo from the first meeting on our Europe of our endocrine society from Endocrinology Research Center around 5 or 6 years ago. And I would like to say my alma mater, Endocrinology Research Center, and now we are on at the international level, and I'm proud of our center. Thank you very much.
Thank you for a brilliant presentation, and unfortunately we haven't the time for other questions. And the next presentation, Marina Grigoryan, Prognostic Determining Factors, Outcome After PCI in Patients with Diabetes Mellitus.
Dear chairmen and colleagues, good morning. It's a great pleasure to address the audience and present our results from Bakulev Scientific Center. This is my disclosure slide. So our investigation was concerned to PCI patients, and we try to find the prognostic factors. So I would like to first to say that when we implant the stent in the coronary artery, there is a triad that influence the adverse events after this procedure. And we can see here that this is the coagulation, and we managed this situation with the heparin perioperatively, and also platelets. So we can inhibit them using dual antiplatelet therapy, and also inflammation. We have no some specific target oral therapy to to inhibit inflammation, but we can use drug-eluting stent that prevent this burden of inflammation after stent implantation. As we know, the dual antiplatelet therapy in stable patients with stable coronary disease consists of clopidogrel and aspirin. But the problem is that clopidogrel have a very response in different patients, and we can see that. We can see that according to different tests, we see this variability after using clopidogrel in our patients. So we have a question that if tailored antiplatelet therapy after PCI is better, and is there improvement of prognosis in patients whom we tailor this therapy? So to assess the response to dual antiplatelet therapy, we have different options. So we have a new method. It's a Verify Now, and we use 2 cartridges, and we can assess the response to clopidogrel and aspirin. Also, the gold standard method is light transmittance aggregometry, the multiplate aggregometry, the VASP test, and the flow cytometry, and the thromboelastography. So what can we use? There is a huge options. So we refer to expert position paper, and where they said that based on the currently available evidence, we can use only 4 of them. It's a Verify Now, it's a LTA, and multiplate aggregation, and the VASP assay. But only three of these tests, it's a Verify Now, multiplate, and VASP assay, has the cutoff levels. So we see this cutoff levels when we can say that yes, this patient is not response to clopidogrel. So we have following proposed to assess the impact of high platelet reactivity and various pro-inflammatory markers on clinical outcomes in stable coronary artery disease patients after elective PCI. We include prospectively 94 patients with stable coronary artery disease. We exclude following patients: patients with acute coronary syndrome, patients with concomitant inflammation, poorly controlled diabetes, aspirin or clopidogrel intolerance, recent trauma, platelet count range of 100 and 415, hematocrit, hemoglobin out of these ranges, and chronic renal failure. After that, we assess the response to dual antiplatelet therapy using light transmittance aggregation and Verify Now test. Also, we assess inflammation markers, so CRP, P-selectin, CD40 ligand, high-sensitive interleukin-6, PAI1, and Willebrand factor activity. After discharge, we performed the PCI with the drug-eluting stent, and after discharge, this patient underwent the genotyping. I'm so sorry. Genotyping, and we follow up this patient up to 5 years. During this follow-up period, we register the cumulative endpoint, That was the major adverse cardiac events, stent thrombosis, angina recurrent due to instant restenosis. The dual antiplatelet therapy received up to 12 months. So this is the baseline patient characteristics. And we can see that most of them were male, and they were smokers. And we can see that diabetes mellitus was more frequent in the group who with the cardiac events after PCI. And also we can see that most of the patients had these risk factors at the hypertension, hyperlipidemia, and they have prior myocardial infarction, and they all receive aspirin. Almost all of them, 93 patients, receive aspirin before they were hospitalized. And more of them received clopidogrel and the statins also before the hospitalization. So during follow-up, we registered acute stent thrombosis in 4 patients, late thrombosis in 1 patient, very late thrombosis in 4 patients, and angina recurrence in 11 patients. And this angina recurrence were due to restenosis. Cardiac death was registered in 2 patients due to chronic heart failure, and 1 patient had a successful resuscitation after malignant arrhythmia. According to light transmitted aggregometry, we received that unresponsiveness was assessed in 15 patients, and according to Verify Now test, it was detected in 23 patients. So after that, we compare patients that they have high platelet reactivity according to tests, LTA and Verify Now, and patients with high reactivity according to one of these tests, and the patients without a high reactivity during dual antiplatelet therapy before procedure. And we can see that the difference was significant. And I would like to mention that patients with high reactivity according to these 2 tests, they had acute stent thrombosis, 4 of them, and 4 of them they have acute stent thrombosis. After that, we perform univariate regression analysis, and we define following factors that influence adverse outcomes after PCI. That was diabetes, PRU level according to Verify Now, 2 and more stented arteries, 2 and more implanted stents, pay level, and factor Willebrand. I want to show you that LTA, the aggregation, had no impact on outcomes, and the genotype also. So using a multivariate analysis, we determine the independent risk factors, diabetes, PRU level, and PAY1 and factor Willebrand. We built ROC curves to determine the cutoff values. Here you can see these cutoff levels, and based on the coefficient of multivariate analysis, we built the prognostic model to assess the risk of adverse effect after PCI. And you can see that the diabetes mellitus is a very strong factor, and it has a 2 point. If patient has diabetes, the risk is very high. And we can divide them according this prognostic model to low risk, intermediate risk, and high risk of adverse events after PCI. And in conclusion, I would like to say that independent predictors of adverse cardiac events after PCI are diabetes, high platelet reactivity according to Verify Now, PAY1 level, and factor Willebrand activity. And also high platelet reactivity according to light transmitted aggregometry, and the genotype had no significant influence on outcomes after PCI in our study population. Thank you for your attention.
Thank you very much for a very interesting presentation. We don't have time for questions. If you have any questions, you can ask them personally during the coffee break. And now I would like to invite the last speaker, Anna Gorbacheva. Long-term prognosis of diabetes patients with critical limb ischemia after endovascular therapy.
So, greetings, colleagues. The goal of my speech today is to cover some aspects of long-term prognosis of diabetic patients with critical limb ischemia after endovascular treatment. Nowadays, there are almost 422 million of patients living with diabetes. The severity of lesions may vary, but there are almost 2% of patients who acquire critical lower limb ischemia. This form is the one which leads to amputations and disability in case of delayed diagnosis and treatment. Critical lower limb ischemia prevalence is high in diabetic patients in 20 times compared with non-diabetics. The frequency of non-traumatic amputations is high too, in 12.5 times. According to Transatlantic Inter-Society Consensus Document on Management of Peripheral Artery Disease, critical limb ischemia diagnosis is stated in the presence of ischemic rest pain, gangrene, ulcers, and proven anterior lower limb occlusion. A long time ago, Avicenna stated that the doctor has only three weapons: plants, words, and knife. We use this quote to demonstrate that in case of critical limb ischemia, only knife still has its pivotal role in treatment, because in complex treatment, the main goal is the restoration of limb arterial bed. This is achieved by bypass surgery or with endovascular treatment. However, there is still a little data on long-term prognosis in diabetic patients with critical limb ischemia after endovascular treatment in our country. So our goal was to evaluate the long-term prognosis in diabetic patients with critical limb ischemia after endovascular treatment with active and non-active follow-up period. And tasks included retrospective clinical and demographic analysis and survival analysis and evaluation of repeated endovascular intervention cases and high amputations frequency during re-examination after 5 years of surgery. Our study included 81 patients. They were divided into 2 groups. Group A, with active follow-up period, included 51 patients. They visited our center every 3 to 6 months, and Group B, which included 30 patients without active follow-up period. Their second visit to our center took place after 5 years from the first operation. Diagnosis and treatment of critical limb ischemia was performed on the task recommendations. So, 90% of our patients suffered from type 2 diabetes, with mean disease duration of 16.5 years. The number of men and women was equal, and the mean glycated hemoglobin level was among 8%. 82% of our patients suffered from hypertension, 5% had stroke in anamnesis, and 18.5% had myocardial infarction. 55% had chronic kidney disease of the first early stages, and 31% had chronic kidney disease of the 3rd to 5th stages. 50% had diabetic retinopathy, and other characteristics you can see on this slide. Groups were comparable in demographic status, level of diabetic complications, and comorbidities. Several scales have been used to evaluate the severity of lower limb arterial lesions. One of them is Graziani scale, which allows evaluating the affected vascular regions basing on angiograms. In our study, 93% of patients had 4th to 6th classes according to Graziani scale. So we can see that all of these patients had more than 2 affected arteries with severe occlusions, mainly in tibial artery bed. Rutherford scale also proved itself useful. It allows setting a category of lower limb ischemia based on severity of symptoms. In our study, 15% of patients had the 4th category, 53% had the 5th category, and 31% had the 6th category according to Rutherford scale. This shows the severity of artery damage. All our patients underwent endovascular treatment, balloon angioplasty, conducted in 2010-2011, sometimes in some cases with the installation of stent. Operated arteries, you can see on this slide. In 96% of patients, we had a good technical success of the operation. After surgery, patients were either actively observed and visited our center every 3 to 6 months, or visited their doctors with less regularity. So the first group was constantly observed for restenosis, and retreatment took place in the case of need. All of the patients were invited to re-examination after 5 years from the intervention, and they were given further treatment recommendations. So it became clear that the group of active and non-active follow-up period were matched for the severity of diabetes complication and comorbidities. In group A, which has been regularly observed, the level of the frequency of high amputations was lower, and the cumulative survival was significantly higher. There was no significantly the level of repeated interventions in both groups didn't differ significantly, but however, there is a trend towards higher level of repeated interventions in group A, which is most likely due to the fact that regular observations increases the probability of detection of recurrence of critical ischemia. So, in conclusion, it's possible to say that critical lower limb ischemia is accompanied by severe morphological changes in vascular and soft tissue, and that active follow-up period can help us to increase the cumulative survival, to decrease the likelihood of high amputations, and that it not significantly affects the likelihood of repeated interventions. Thank you for your attention.
Thank you very much for a brilliant presentation, brilliant results. Thank you. And I think we don't have enough time for discussion, and we can continue with the diabetic foot problem. And I would like to invite here our dear Professor Edward Jude from UK with his lecture, The Charcot Foot in Diabetes. Please welcome.
Thank you. Is it working? Thank you. So thank you very much for the invitation to speak at this excellent conference. Thank you to Katrina for all the organization. It's been a great day, and I think you've done a fantastic job. Lovely. So I've been asked to speak on the Charcot foot. So before I start, can I ask how many of you here actually do work in the diabetic foot clinic? How many of you all see foot patients? Yeah, and how many of you seen Charcot feet before? Excellent. It's not a very common condition. In the UK, in my clinic, I probably see 10 acute Charcot foot in a year. And if you look at general practitioners, they probably see 1 case or less in a year. So it's quite uncommon, and therefore it's quite common that doctors can mistake the diagnosis or not diagnose it as Charcot foot until it's quite late. So what we need to do is to raise awareness in the diabetic foot clinics. And to do that, we did an audit in the UK where we looked at 320 patients with Charcot feet, and that was to raise the awareness among all the foot clinics, but also amongst general practitioners. So I'll be talking about the acute Charcot neuroarthropathy, how to diagnose and manage this condition. So the Charcot foot were first described by Jean-Marty Charcot in 1868 in France in La Salpêtrière Hospital, where we were privileged to visit and do the consensus on the Charcot foot, which I'll discuss a little later on. But when Charcot first described this condition, it was actually in tabes dorsalis, in this young woman here who had tertiary syphilis, developed neuropathy, and then went on to develop changes that we know today of the Charcot foot. But it was James Paget who first brought this condition to the English-speaking world, and it was him who coined the term Charcot's disease. So James Paget, you know, is quite famous for the Paget's disease of the lower limbs, of the long bones, and he presented this case in London, and he coined the term Charcot disease. But it was not until 1936 when Jordan described the first case in a patient with diabetes. And this is because prior to this, patients with diabetes were not living long enough to develop these complications. After 1922, when we had insulin discovered, and people were now living long enough to develop complications of diabetes. So how do we define the Charcot foot? I've got a very simple definition, and is defined as the simultaneous presence of bone and joint destruction, bony fragmentation and remodeling, resulting in severe foot deformity. And the typical deformity that we see in the Charcot foot is what we call is a rocker-bottom deformity. So normally if you look at your foot, we all should have a normal plantar arch. Okay, so this is your plantar arch. And when people get Charcot foot, because of bone and joint subluxation and breakdown in the bone structure, they tend to lose the plantar arch, and then they get what we call is a flat foot. And if they keep walking on this foot, because of constant pressure on the bones of the feet, they then get what we call is a rocker-bottom deformity. So it's a reverse of the plantar arch, and then the foot becomes this shaped, where they walk on the bones of the midfoot, and it's like walking on the pebble. And this pressure caused on this bony deformity leads to foot ulceration, osteomyelitis, and ultimately these patients go on to have an amputation. So this is the mainstay in our treatment, is to prevent patients from getting this severe bone destruction and bony deformity. Now it's 150 years ago before Charcot first described this condition, and we still don't know how to manage this condition. We don't know what causes it, we don't know what the etiopathogenesis is, and therefore we set up this consensus in 2011. It was a global consensus, and we were lucky enough to be able to visit the hospital where Charcot actually worked on his cases, and we then also visited his house in the evening. It's now become a museum and a restaurant. So we were very privileged to visit this place in Paris, and I would recommend you all to go there, because in La Salpêtrière Hospital, all Charcot's work, his publications are all out on display for people to come and see. So this consensus was headed by Lee Rogers from America and Lee Sanders, both quite famous podiatrists in the US. David Armstrong from the US. You got Bob Freiberg there. You can just see his golden hair in the corner. Andrew Bolton, myself from the UK. Alexandra Rakowska from Czech Republic. Stefan Mobach from Germany, etc., etc. So we had global representation to come together and write up this consensus. And it was published in Diabetes Care in the September issue of 2011, and it's free to download from the internet if you wish to download and read the consensus. So the first thing we looked at is how do we classify the Charcot foot? There's been various classifications in the past, and we thought that some of them were quite confusing. So we thought we'll come with two very simple clinical classifications, because Charcot foot disease is a clinical disease. And we came up with these two classifications. We can either call it an active or an inactive Charcot foot, where the active Charcot foot is when the inflammation is ongoing and the foot is warm and swollen. And once the inflammation settles down, you then go on to develop an inactive Charcot foot. Or we can call it acute or chronic, where acute again is an ongoing inflammatory process, and once the inflammation settles down, it then goes into a chronic or a quiescent phase. What we couldn't define is when or how long can the foot remain acute. If somebody's got a foot ulcer, if the foot ulcer is more than 4 to 6 weeks in duration, you then say the patient has got a chronic foot ulcer. But we couldn't say that we can have a cutoff time point of 6 weeks or 6 months to say that somebody's gone from acute to a chronic Charcot foot, because an acute process can go on for months or sometimes even years. What about the epidemiology? It's not a very common condition, and it's present in about 0.1% of people with diabetes. So that's 1 in 1,000. But if you look at people with neuropathy, and we did this study a few years back in Manchester, where we x-rayed about 100 patients with neuropathy, and we found that just over a quarter of them had changes in the foot which we could classify as being Charcot. Not acute or chronic, but just Charcot disease in about a quarter of patients. It can occur both in males and females, and generally occurs around the 5th to 6th decade of life, though I've seen a young girl of 25 who had Charcot foot, and people in their 80s. So it can occur at any age, but the most common age is in people in their 50s and 60s. It can be seen both in type 1 and type 2 diabetic patients, and generally occurs in patients who have very long duration of diabetes, more than 10 years. But again, I've seen patients who present to the orthopedic surgeon, or who have presented to the orthopedic surgeon with a hot swollen foot. The surgeon thought that the patient had osteomyelitis, did a bone biopsy. The bone biopsy was sterile, and then found that the patient had diabetes, referred to the foot clinic, and the patient had an acute Charcot foot. And the reason for that is we know from the UK PDS that we are diagnosing type 2 patients 5 to 8 years after they develop diabetes. And we know from the UK PDS that up to 20% of type 2 diabetic patients at diagnosis can have microvascular disease, including neuropathy. So if they had neuropathy for 5 to 8 years, they can go on to develop Charcot foot and present to us with a hot swollen foot rather than because of hyperglycemia. And then you do a blood sugar and you found that they've got diabetes. So the teaching that I do in the UK and in our hospital is any hot swollen foot, think of Charcot foot, whether they have or they don't have diabetes. So what about the etiology? Again, in the Western world, diabetes is the most common cause for Charcot foot. But globally, there are so many other causes. Diabetes dorsalis, which is fortunately not seen that much nowadays since the discovery of insulin, conditions like syringomyelia, spina bifida, meningomyelocele. All these patients are born with congenital disorders that can lead to peripheral neuropathy, giving rise to Charcot feet. Leprosy is not an uncommon cause in India. We run a diabetic foot workshop in the leprosy hospital in India every year in January, February. And I've seen lots of patients who've got leprosy, lepromatous neuropathy, giving rise to Charcot feet. Chronic alcoholism, we published 2 cases last year in the BMJ. Patients without diabetes, alcoholic neuropathy, developing Charcot feet. And of course, all the other causes I've listed here. So like I said, it doesn't have to be diabetes, but always look for diabetes when somebody presents with a hot swollen foot. So coming now to the pathogenesis. So for a patient to develop a Charcot foot, this patient should be susceptible to developing this condition. And the susceptibility is because of the presence of neuropathy and autonomic neuropathy. Studies done in London have shown that patients with neuropathy and underlying autonomic neuropathy, when you do blood flow studies in the bone, there's increased blood flow in the bone. And this is more commonly seen in people with advanced neuropathy, people with Charcot feet, compared to patients with diabetes without any underlying neuropathy. So the presence of autonomic neuropathy and peripheral neuropathy leads to increased blood flow, leading to increased osteoclast activation and osteopenia. So this leads to bone resorption, osteopenia, and osteoporosis, and the foot that is now susceptible to the development of Charcot neuroarthropathy. But what brings this on? There has to be a triggering factor, and the most common triggering factor is trauma. But because these patients have quite severe neuropathy, they don't recollect having had the trauma a few days or a few weeks prior. And this triggering factor then leads on to inflammation in the foot, and this inflammation can progress if the patient keeps walking on that inflamed foot, leading to the changes that we see in the Charcot foot. So to understand a bit more on what's happening in the Charcot foot, we thought we'll do some studies looking at the bony changes. And this study we did with Texas, San Antonio, with my friend Lafontaine Javier, who's the first author on the paper. And we did biopsies from the bones in the feet of people without diabetes, patients with diabetes and diabetic neuropathy, and Charcot feet. And we stained the bone for CGRP and eNOS. So CGRP is calcitonin gene-related peptide, and eNOS is endothelial nitric oxide synthase. And we wanted to see what was the presence of these two cytokines within the bones in the feet of people with Charcot feet and those without. And what we showed is that patients who did not have diabetes, as you can see, the brown staining is for CGRP on this row here, and on this row it is for eNOS. You can see the heavy staining of CGRP and eNOS in normal subjects. And then when you go on to look at patients with diabetic neuropathy and ultimately Charcot feet, you can see the reduction in CGRP and eNOS. It is these two enzymes that inhibit the osteoclast activity, and because of the lack of these enzymes, you lead to increased activation of osteoclasts, leading to the bone resorption. To take this one step further, we then went on to look at Rankel and osteoprotogerin in people with diabetes and Charcot feet. So Rankel is receptor activator of NF-kappa B. And this receptor, when it's bound by its ligand, RANKL, it leads to the activation of pre-osteoclast to osteoclasts. So the pre-osteoclast is inactive. It cannot cause bone resorption. The pre-osteoclast has to be activated to an active osteoclast, and this then goes on to lead to bone resorption. A lot of studies have been done in osteoporosis, looking at Rankel and OPG. OPG is a cytokine that blocks the binding of Rankel to its receptor. So in other words, OPG is a decoy receptor for Rankel. If there is less OPG within the blood, then Rankel can bind to the receptor, leading to osteoclast activation and bone resorption. So what we have here is the Rankel. This is made by various cells, including macrophages, osteoblasts, endothelial cells, etc. And then you got the OPG. This is the pre-osteoclast, and you have the RANKL binding to RANK and activation of the osteoclast to form active osteoclast, which attaches to the bone, leading to bone resorption, osteolysis, and then osteoporosis in the end. But if there's enough OPG, then there's less activation of pre-osteoclast to osteoclast, leading to bone being preserved and preventing bone resorption. So we wanted to see what happens to the serum in patients with Charcot feet and those without. So we took serum from patients without diabetes, patients with neuropathy, and patients with Charcot arthropathy. We first looked at the serum RANKL levels, and these are controlled non-diabetic subjects, and you can see they've got low RANKL levels, slightly higher levels in people with diabetes, and much higher levels in the serum of patients with Charcot neuroarthropathy. We then looked at the OPG levels, and as you would expect, there were high OPG levels because we should all have high OPG levels to prevent the RANK L from attaching to the receptors in our osteoclasts and preventing osteoporosis. So we need to have more OPG than rank L so we don't develop osteoporosis as we all grow older. So there was higher rank OPG levels in patients with diabetes and Charcot feet compared to non-diabetic patients. But what's important is the ratio of rank L to OPG. What you want to have is enough rank L, enough OPG. So the OPG blocks the rank L and then doesn't prevent bone resorption. So we need to look at the rank L OPG ratio. And this is what we looked at here. And you can see now that the rank L OPG ratio was quite low in patients in people without diabetes and people with diabetes but without Charcot feet. So patients without Charcot neuropathy had enough OPG to block the rank L activating the osteoclast. But in patients with Charcot feet, you can see there's a quite high rank L OPG ratio in favor of rank L. This is what leads to the bone resorption, and we feel that this is what causes, or one of the causes, of Charcot neuroarthropathy in people with diabetes. So just to summarize quickly, this is something we published a couple of years ago, and we put up a pathogenesis encompassing all the changes that happen in the Charcot feet. So first you have hyperglycemia. This leads to activation of various cytokines. I won't go through this in detail, leading to changes in the cytokines interleukin 6 and TNF-alpha. A nice study done in the US, again on bone biopsies, showed increased IL-6, IL-1 and TNF-alpha in Charcot feet compared to patients without Charcot arthropathy. So these changes of increasing cytokines leads again to increased rank L production and ultimately Charcot neuroarthropathy. Similarly, reduced eNOS, as what we showed in our study, leads to decreased CGRP and again increased rank L production. So one of the treatment options would be to block this rank L activity on the osteoclast and hopefully then go on to prevent patient developing this condition of Charcot neuroarthropathy. So how do we make the diagnosis? Obviously, first we need to make the diagnosis before you can treat this condition. So to make the diagnosis, we need to take a good history. And this is quite often lacking in the clinics because people are so busy and they see a hot swollen foot, they always think is infection, give them antibiotics, send the patients home, and then when they come back a few weeks later, they've now developed severe foot deformities. So it's important that we can take a good history, do a good examination, and then do some x-rays to make the diagnosis. So the diagnosis should always be clinical. Okay, so any patient presenting to you with diabetes and the hot swollen foot, you need to think of Charcot foot. If you were to check the temperatures, the normal differential between the 2 feet should be less than 1 degrees. Okay, so we've got we call it a temperature gun. It's actually a thermometer. You apply it to the foot and it'll check the foot skin temperature. And if you check on one foot and the other foot, the difference should be less than 1 degrees. If it's more than 2 degrees, then you need to think that this patient may have Charcot arthropathy. There's been a couple of cases, and we just saw a patient recently who never had an increase in more than 1.5 degrees centigrade. So it may be that some patients may not have this fulminant inflammation that you tend to see in most patients. So just remember and keep it in mind, a hot swollen foot that is not warm could still be Charcot foot. But in 99.9% of cases, the temperature differential between one and the other foot will be more than 2 degrees. So what we therefore need is a high index of suspicion. If you don't think about Charcot neuroarthropathy, you will not make the diagnosis. If somebody comes to your clinic with chest pain and you don't think that this patient is having a myocardial infarction, you may think he's got reflux esophagitis, musculoskeletal pain, you might send the patient home. So any patient coming to your clinic with chest pain, you think, does this patient have a heart attack? Or is the patient having a myocardial infarction? So any hot swollen foot, think of Charcot neuroarthropathy. So how to make the diagnosis? Red hot swollen foot. Inflammation is the earliest finding. And then with persistent walking, or repetitive stress injury to the foot because of walking, they can go on to develop the deformities that we see. But what we want to pick up these patients, or identify these patients, is when they come to us in the stage 0 phase, what we call the prodromal stage. And this is the most common errors that are made in diagnosis. Okay, we think that the patient may have cellulitis, send them home on antibiotics, or they may have a deep vein thrombosis and do Doppler scans to try to rule out a DVT, maybe put them on treatment, and then call them after a few weeks without offloading. We think they may have gout because they've had gout in the past, and it's not unlikely that patients can have two different conditions, gout and Charcot foot, so always think of the other one, and osteomyelitis. Any adaptive patient who comes to the clinic, hospital and foot, we always think, have they got an infection? Okay, but now we need to think, do they have an underlying Charcot neuroarthropathy? So the recommendations for diagnosis from the Charcot consensus was the occurrence of swelling or fractures or dislocations in a neuropathic individual. Always think of Charcot neuroarthropathy. And plain X-rays should be the first line treatment in these conditions, because we can get an X-ray, at least in our hospital, within 20 minutes. It takes a day or two to get an MRI scan, another day or two to get nuclear scanning. But an X-ray can be done while the patient is waiting in clinic. So it's not difficult to do an X-ray, and most patients can be identified on the foot X-ray. So what are the changes you'll see? This is a foot X-ray for a patient. In a normal foot X-ray, the medial aspect of the second metatarsal head should be in line with the medial cuneiform bone. But because of Charcot changes, there's now subluxation of this joint and lateral movement of the medial of the second metatarsal head. And therefore you get this change here, where the medial edge of the second metatarsal bone is now not in line with the medial edge of the cuneiform bone. And this is what we call is a Lisfrank's joint, because the surgeon Lisfrank's first diagnosed this many, many years ago. So these are some of the early changes you will see in the Charcot foot. You may not always see a Lisfranc joint, depending on where the deformity is occurring. It could be happening somewhere here, or could be happening also in the toes or in the ankle. But this is one of the most common findings that you would see if you do a plain X-ray on the foot in somebody developing a Charcot foot. And then, of course, you can go on to do other investigations. You can get severe midfoot deformities. This is a typical rocker bottom deformity. You'll see destruction of the midfoot, as seen in these pictures here. And then you may want to do an MRI scan. And the earliest change you'll see on an MRI scan is bone marrow edema. But to the untrained eye, that's very difficult to identify. So what we need is a good musculoskeletal radiologist who's looking at foot X-rays on a regular basis. And he can identify these subtle changes, so we make an early diagnosis in the presence of normal X-rays. If the X-ray is abnormal, and you're seeing X-rays like these, you don't need to do an MRI scan. We tend to recommend MRI scanning if somebody's got a normal X-ray, so we can identify the condition before they get these severe bony deformities. So this here is a patient of ours who had an osteomyelitis. He then went on to have an amputation of his first toe. He came back 2 months later with swelling of the foot, and we thought he's got osteomyelitis again because of the previous infection. We did a bone scan, and this is a bisphosphonate technetium labeled bone scan. So by adding bisphosphonate to the technetium will hone in onto sites of inflammation in the bone. So this is a bisphosphonate technetium labeled bone scan. You can see increased uptake in the midfoot compared to the opposite foot. And we thought, this could be Charcot, this could be infection because of his previous history. So we then went on to an indium labeled white cell scan, and this is used to identify if there's infection. And the hot spots that you're seeing on the technetium labeled bone scan, there's no hot spots on the other foot. So this patient did not have infection, he actually had a Charcot foot. So we put him in the cast, and then the foot healed over time. So sometimes you may want to rule out infection. MRI scanning again is the treatment of choice. If the MRI scan is negative, or the radiologist said, I can't make out, because sometimes there can be difficulties in differentiating Charcot from infection, you may then want to do either an indium labeled scan, or we do an FAB scan nowadays to identify infection in the diabetic foot. So what's the natural history? So usually patients present to us first in the stage 0, what we call the prodromal period, and this is the time when they have a normal X-ray, but they have subtle changes. There may be a Lisfranc joint, or it may be completely normal, but the foot will be hot, red, and swollen. It then goes on to stage 1, or the stage of development, when they start developing fractures, bony subluxation, and then they move on to stage of coalescence, when the foot tries to heal itself, and then into a stage of reconstruction and quiescent. So this is the acute phase, when is the best time to pick up these patients, because if you put patients into a cast, take them off their feet, you might be able to prevent them going from the prodromal stage to the stages of bony destruction. So what's the treatment? The treatment can be medical or surgical. I'll just be speaking today about medical treatment because of lack of time. So the treatment is to convert from an active to an inactive phase, preventing further deformity, providing protected ambulation, and then preventing foot ulcerations. Because it's ulcerations that lead on to infection that then lead on to amputations. So if the patient does develop foot deformity, we've got to prevent them from getting foot ulcerations and infection. So the mainstay of treatment is offloading and bed rest. Sometimes we give patients crutches or even wheelchairs to take their feet off the ground. We have tried various pharmacological treatments in the past, and I'll be presenting some research that we've done. But because these patients have got very high recurrence, they require continuous follow-up over long term, because they can get recurrence of the Charcot foot, or the other foot can develop similar changes. So the management is non-weight bearing and immobilization. So if somebody presents to you with a foot that is still got the plantar arch, and you suspect in the patient got Charcot foot, you put them into a cast, and you put the cast so that it covers the arch. So when the patient walks, it doesn't let the foot losing its arch. Okay, so you preserve the arch if possible, and keep the patient cast until the inflammation settles down. And to do that, we use a total contact cast. So the gold standard for treating a Charcot foot is a total contact cast. And we do this in our clinic when the patient presents to us straight away. We don't let them walk home without going into a cast. So there's no pressure being put on the foot. Of course, some centers are not geared up or don't have the expertise to put the total contact cast on patients' feet, or they have complications. So these patients can go into an air cast. An air cast is not the gold standard. It is secondary to a TCC if patients cannot be put into a TCC. So how long do you need casting for? This is some work but done by Armstrong and colleagues. You can see it's quite an old study, because there's been no studies done after that. And people require casting for around 5 to 6 months. In our series that we did, it was between 4 and 6 months. And once the patient comes off the cast, they go into intermittent footwear, or CRO, we call Charcot Restraint Orthotic Walker, which they wear for a month or 2, and then they can go into bespoke footwear. So it takes about 5 months for the foot to settle down, though sometimes it can take over a year. We've got patients in cast for over 12 months, and then you suspect, are these patients going to get better or not? Do they need to be in the cast for so long? Maybe just take them off the cast. But you tend to keep the cast until the temperature differential between the 2 feet is down to less than 2 degrees. What about pharmacological management? So if you look at what we know so far about the pathogenesis of the Charcot foot, we know that there's bone resorption, we know there's increased Rankel activity, and we know there's increased cytokine levels within the bones and within the serum of these patients. So maybe we can tackle each of these pathways to try and prevent the Charcot from occurring, or once it happens, to prevent the inflammation or reduce inflammation and preserve foot shape. So for anti-resorptive treatments, we've looked at bisphosphonates and calcitonin, and I'll show you the research that we've done. Rankel inhibitors, there's a trial going on in Australia, which we've initiated in Sydney and Melbourne, and then we're looking probably in the future at looking at cytokine modulation. So with bisphosphonates, we've had trials that have been performed. There have been 4 trials performed, 3 RCTs, 1 non-randomized controlled trial, and all the trials have shown symptom improvement. They've shown reduction in bone resorption markers and improvement in bone density. And 1 study has looked at time to casting. However, none of these trials have shown any improvement in the endpoint, which was temperature differential. So this is the first study that was done in Charcot-Foot. This study we did in 2001, published in Diabetologia, and we had 39 patients across the UK who were randomized to receive either placebo in yellow or active treatment, which was 90 milligrams of pemidronate intravenously given over 3 hours as a one-off infusion. Patients were then followed up for 12 months, and we looked at symptoms. There was a definite reduction in symptoms. Although these patients have got severe neuropathy, they do have pain as a predominant symptom. So we followed them up and we asked them about their pain symptoms in those who had the infusion versus those who had placebo treatment. And we showed a reduction in symptoms over the next 12 months. We then looked at temperature differential, and you can see that there was a reduction in temperature in both the groups, because giving offloading will bring down the temperature. Just keeping patients' foot off the ground will reduce the temperature because you're bringing down the inflammation. And then patients who had the bisphosphonate, there was a further reduction in temperature over the next 2 to 4 weeks, but there was no difference between the two arms. We then looked at TPT crosslinks, which is measured in urine, and this is a bone resorption marker, and we show significant reduction in bone resorption over time, and also reduction in bone-specific alkaline phosphatase, which is a bone formation marker. So although we showed that giving bisphosphonates will affect the underlying pathogenesis, there was no change in the actual disease activity, and this may be because of lack of power in the study. Another study done using alendronate 70 milligrams once a week, this versus placebo. This was done by Piteco and colleagues in Rome and other centers. And they again looked at symptom score, and again symptoms reduced, but there was no difference in temperature. So again, there was no effect on disease activity. They also looked at two bone resorption markers, one CTP and hydroxychloroquine, and again you can see there was a reduction in the bone resorption markers compared to placebo. They also showed improved in bone density. So again, bisphosphonate can not only reduce the bone reabsorption, but also improve bone density, which we know is reduced in people with Charcot feet. Now, because you can't use bisphosphonates in renal failure, we thought we'd look at a different compound called calcitonin, and calcitonin also works through the Rankel OPG pathway. And this study we did with Prague University, and we had 39 patients. I'm going to skip this slide. Calcitonin. So we looked at 32 patients who were randomized to receive intranasal calcitonin versus placebo. And again, we showed improvement in bone resorption markers, but no improvement in bone and disease activity. But because it is safe to use renal failure, patient with severe acute inflammation in the bones, you could probably use calcitonin to reduce the bone inflammation. What about other treatments? So Rankel inhibitors, denosumab, is being used quite widely in osteoporosis, and this is something we can think of for using in Charcot feet. You got IL-1 beta inhibitors, IL-6 inhibitors, and of course interleukin 6 inhibitor. All these have been shown to be increased in patients with Charcot neuropathy, and these are some of the treatments that can be trialed in the future. Just looking at RANKL inhibitors, this is a trial we're doing in Australia using denosumab, and it's a 2-phase study, an open label study followed by an RCT, which is ongoing at the moment. So what's the diagnostic algorithm? This is again in the consensus, and you can find this in the paper online. So somebody presents with a hot swollen foot, and you suspect that the patient may have Charcot neuropathy. You do an X-ray. If the X-ray is positive, you make the diagnosis and you put the patient into offloading. If the X-ray is negative, then you want to do other investigations, an MRI or a nuclear scan. If that's negative, then the patient probably has got osteomyelitis. Treat for osteomyelitis with antibiotics. If the scan is negative, the patient does not have Charcot foot, and then you can discharge the patient from a clinic, but look for other conditions causing the hot swollen foot. If the MRI scan is positive, again the patient needs to go into offloading, and after consolidation, the patient can go into permanent footwear. If the offloading is ineffective because the patient now develops severe foot deformity, then the patient will need some form of surgical reconstruction, what we call ostectomy, or improvement in the foot shape, and then the patient goes into offloading and ultimately into bespoke footwear. But because these patients can develop Charcot foot again in the future, or develop condition on the other foot, these patients do need long-term follow-up and should not be discharged from the foot clinics. So who should manage these patients? And we always recommend that the patient should be managed in the multidisciplinary team setting. Okay? And who should be involved within that team? Every person on this list needs to be within that team, and this list is not exhaustive because you need a radiologist, you might need a microbiologist, you might need an infectious disease specialist. But these are the main players in the teams. Okay, so you need a diabetologist, and in the UK, most of these clinics are run by the diabetologist. There's some centers in Europe where you may have an orthopedic surgeon or a vascular surgeon who may be the head of this clinic. We then need a general practitioner because most of these patients are followed up in primary care. In the end, you need a vascular surgeon. Of course, you need a carer because these patients usually are immobilized or in a crutch or a wheelchair, so they need somebody to look after them. You need a plastic technician to put on the total contact cast, an orthopedic surgeon if they require foot deformity correction, hospital nurses if they come into hospital, diabetes specialist nurse to improve their glycemic control because most of these patients do have quite high blood sugars, high HbA1cs, podiatrist to look after the feet, to put on the cast, as happens in our clinics. Though in other clinics they have a plastic technician, but they may get foot ulcers, so they need a podiatrist and the primary care nurses. But the most important patient in this team is the patient, because if the patient does not follow your advice and the patient does not agree to use his crutches, wear his offloading device, or reduce his activity, we're not going to reduce the bone inflammation. And these are the patients who are very high risk for going on to develop these severe foot deformities. So in summary, after all I've presented to you, we are still not very far off, despite having the consensus meeting, to understand a lot about the Charcot foot. We still need a better understanding of the pathogenesis. The trials that we have and others have done bone biopsies, we've done serum levels, but we've not shown that by treating this condition, can we reduce these serum levels of these various cytokines or improve the bone architecture. Because these trials are difficult to do, patients are not that commonly seen in our clinics, and therefore we need a more collaborative working. And all the trials that have been done so far have been in small patient numbers. So we need large randomized controlled trials in collaboration with different centers, but also maybe different countries. So in conclusion, early diagnosis is crucial. I think thinking of Charcot when the patient presents to you with a hot swollen foot is important. And if that's one take-home message I can pass on to you when you leave this room today, I've done my job. Because I think this is the condition that is very often misdiagnosed until 3, 4, 6 months later. And we've seen patients coming with severe foot deformities, severe ulcerations, because people have misdiagnosed the condition and have not referred these patients to our clinic in time. The treatment is total contact casting with immobilization. This is the mainstay of treatment. We can use pharmacological treatments such as bisphosphonates. As you know, the trial evidence has been negative, so we would tend to use bisphosphonates in somebody who's got a very highly inflamed foot, and then give them bisphosphonates. And I tend to use IV pimidronate. But we need newer therapies, we need new trials, and we need to have evidence in the near future. Thank you. Any questions? Yes, Katrina.
Dear Professor Edward, thank you very much for your presentation. It's most interesting for me as a diabetologist, especially like seeing patients with diabetic foot, but not being a pathologist and specifically involved in that. My question is more organizational than scientific. As far as I know, my colleagues will correct me if I'm wrong, in Russia we have a problem that like we have very good centers like here in Moscow, but Russia is big, and in many even regions we don't have centers which can provide care to patients with Charcot foot. So I would like to know how it's organized in the UK. Are there many centers like yours, very like with high qualification and experience in this field, or it's just unique? I also wanted to ask what team do you support, but now I see there is no need. Yeah, you support Manchester United. Thank you.
Thank you for that excellent question. I think it's such an important question because when I give lectures like this around the world. I get asked that question quite often. And I can give you two examples. One is Brazil, where Linda Pedrosa, who started 20 years ago, working in the diabetic foot, and they had no foot clinics at all in Brazil. And she started the first clinic in her hospital in Sao Paulo. And then she started getting involved with the government, because that's the best way to do it, is to involve the government. In the UK, NICE draws up guidelines, and we've been working with NICE to get up some of these guidelines. And once it becomes the government directive, then it happens. So in Brazil, from no clinic to one clinic in the capital, she's got now over 30 centers across the country. In the UK, every hospital has to have a foot clinic. Not everybody has the expertise that some people have. Is because of interest, and it's because of one, whether they have the time to do it, two, whether they have the interest to do it, and three, whether they've got the supporting structures. So in the UK, we are helping other centers. That's why we did the CD UK study to raise the awareness on the Charcot foot. The same thing in India. There are no foot clinics, and people coming with deformities very often have amputations. So I've been working with the IDF president, who, as you know, is now from Mumbai. And we are looking at putting out adverts, sending tweet messages to people with diabetes, television, newspapers, etc. So raise the awareness of the diabetic foot in India, which is a vast country with a huge population. We do regular training programs there. I do one in the leprosy hospital, but also in other centers. So the important thing is having a champion who will push this through with the government, but also push this through with colleagues and clinicians. Very often these patients are seen by general practitioners, which is where the delay happens, because the GPs see one patient every 2-3 years, and they would not suspect that this patient is having a Charcot foot. So it's raising the awareness not amongst diabetologists, endocrinologists and specialists, but also among general practitioners, because those are the people who are seeing these patients first off. And that's what we're trying to do in India at the moment, is going out into primary care, going out into the villages, raising the awareness of diabetic foot, not only Charcot, but also foot ulceration and other conditions. Thank you.
Thank you very much. And do the reconstructive surgeries are performed in your clinic, or you have another department, another clinic where it is performed?
So that's the important question. I didn't have the time to cover surgery because there's another whole talk in itself. But when the patient presents with an acute Charcot foot, we do not recommend surgery, at least in the UK and in Europe, because the bones are so malleable, they're so fragile, that if you go in and put pins and plates and screws, these metal bits will not hold. Though the thinking in America, and they have to be different in the US, they do recommend early surgery. But what we feel is that if people are picked up early enough and they're casted, you can prevent them having foot deformities. The other issue, of course, is weight. We know that in the US, people have got a much higher BMI compared to people in Europe. And I think weight might probably play a feature in why they want to go for early surgery in the US, because I've seen patients in the US with quite severe deformities that we don't tend to see early on in the UK. Coming to surgery, it depends on the foot deformity. If they've got severe foot deformities, then we do refer them to specialists, and there are a few specialists in the UK who are what we call foot and ankle surgeons, and they only deal with these severe foot deformities. If they've got early, just for simple fractures, for example, then we would refer them to our local orthopedic surgeons. But if they require extensive surgery, then we would refer them to a specialist foot and ankle surgeon.
Thank you.
Thank you.
Very nice overview. I was wondering, when you treat the patients with the immobilization therapy, so the cost you explained to us, should we treat the patients parallel with anticoagulant therapy, or is that not necessary?
So that's an excellent question. And so the two points there. One is when we put people into a cast, we don't leave them in the cast for weeks and weeks and weeks, because moment you put them into a cast, the swelling comes down, and then they get what we call this pistoning. So you got the cast there, you got the foot that is sitting nicely because it is a total contact cast. But the moment you put them in the cast, the swelling starts to come down, and then the foot becomes loose in the cast, and then the foot can move up and down. Okay, that we call this pistoning. And if there's movement in the cast, then the cast tends to rub and they get foot ulcerations or leg ulceration, depending on where there's maximum pressure. So we do recommend that the cast is taken off 1 week after it's applied, and then 2 weeks, then 3 weeks, then 4 weeks. Because as time moves on, once all the swelling is gone, then you're only casting the bony deformity and not the swelling. Do these patients require anticoagulation? Most of these patients will be on aspirin or clopidogrel. We don't recommend giving them anticoagulation, but that's a good point, especially if we recommend complete bed rest, which is not that common. We do recommend they mobilize, but not a lot. Okay, a lot it can vary from patient to patient, but we do say that they should walk about at least a little bit, but not go on long walks and do extensive amount of activity. So we don't normally recommend giving them warfarin or one of the NOACs.
Okay, thank you.
And what about the use of NSAIDs? Are they helpful in the initial phase?
Okay, that's such an important question, because I think in the earlier days we used to use a lot of non-steroidals. There's no trial evidence that non-steroidals help. Two, we know that these patients have already got compromised kidney disease, and I think we should not be using non-steroidals in people with diabetes per se, leave alone people having Charcot foot. A lot of our patients are being prescribed non-steroidals for arthritis and other conditions, and I actively take people off non-steroidals. Okay, so we do not use non-steroidal for this condition, and I don't use it in people with diabetes anyway, because it can lead to kidney damage. Okay. And there's no evidence. Okay, thank you very much.
Thank you very much. It's a great honor for us to hear your lecture. Thank you very much. And now we have a break, a coffee break for 10 minutes, and then we'll come back here to continue the next session. Thank you.
Dear colleagues, can we start our next session? Aren't you against? Okay, we will start, and I think some more colleagues will come to us in several minutes. I'm very happy to see you here in Moscow, in our center, and it's great pleasant to us to see you, to hear you, to know you, and to meet you in this conference. We have not such more time for our scientific team as we maybe wanted, and I'm sorry. And we should start already. We have 4 lecturers for 10 minutes for each presenter. So if our first presenter is already here and ready to present the investigation, please come to us.
And our first presenter, Dr. Francisco Varilas Solana, and his presentation about early glucose intolerance postpartum of gestational diabetes associated with overload test with 50 grams of glucose.
Thank you very much. As you can see, our presentation is about gestational diabetes, the proof early glucose intolerance postpartum associated with overload test with 50 milligrams of glucose. This is our hospital in Spain, in Canary Island, Hospital de Fuerteventura. Well, all the people know the glucose intolerance later gestational diabetes is a very important indicator that helps establish the prognosis in diabetes in pregnant women who had gestational diabetes. In this study, we followed for 1 year to all gestational diabetes who were treated in a hospital of Fuerteventura in endocrinology consultation, Spain. Sorry. The aim was to study what factor might be related to glucose intolerance in immediate postpartum. Well, all the pregnant women served to diagnosis of gestational diabetes during April 2012 and May 2013, diagnosis according to the criteria of the ADA, were subjected to routine procedures to specialized gynecology and endocrinology units. First test was loading with 50 grams of glucose, and then if the glucose was more 140, and ACE-OG was performed with 100 grams of glucose. This is usually, perhaps in all the world. Well, all the patients was followed with a minimum and monthly review for both gynecologists and endocrinologists, and was given a standard diet and as control, if necessary, insulin treatment. You can see here the glycemia control, and in the second quarter we made a glycosylated hemoglobin, and in the third quarter we made glycosylated hemoglobin. Results. We followed 60 diabetic gestational patients, and 49 complete the assessment of urea glucose tolerance test at 0 and 120 minutes. I told you that was 6 weeks to 12 weeks after the birth, this proof. The total, 81.7%, 57.1 were normal. 42 had any category of glucose intolerance. 26.5 were impaired in fasting glucose, and 14.3 were really intolerant. 2.5 were diabetic. It's more clear here in the table that show all these results. In these patients, 57.6% had a vaginal delivery, normal, and 39 were dystocia. Then we analyzed all the variables according to the diagnosis of glucose intolerance, and only just correlated 50 grams of glucose with the test ANOVA with a significantly p less 0.04 with degrees of impaired glucose tolerance. And it's very important to show these results too, that was a correlation positive linear between higher blood glucose value post 50 grams and glucose intolerance in the immediate postpartum. Immediate postpartum, that means 6 weeks to 12 weeks after the birth. When we analyzed dystocia, there was no correlation with any of the variables studies. You can see here all of these, the variables, number of gestation, family history of diabetes, previous gestational diabetes, HbA1c, second quarter, third quarter, no correlates, only correlates with the test of 50 grams. In this image, can you see here how this is a positive linear correlation between the results for 50 gram test glucose over lead and more glucose value, more related to impaired glucose in diabetes gestational. Well, conclusion, interesting in this study is it is among correlation values loading with 50 glucose and the presence of glucose intolerance and diabetes immediately after birth of gestational diabetes. We know, all the people know that 50 grams of glucose, more than 200 glucose, has in almost certain chance to having gestational diabetes. And according to some centers, especially in United States, it's not necessary to make a confirmatory is OG if they have more than 200 milligrams. However, their relationship to the immediate postpartum in our study, in our set, is no, we don't know any other study like our study. And therefore, part of the predictive value for gestational diabetes could already give us an indication of glycemic alteration itself will happen in the immediate postpartum. Finally, compared with other studies, the prevalence of glucose intolerance is similar to other high-risk populations, such as the Indian population, what gives us and our population, Canadian, high risk to developing diabetes in the future. This study showed that overload test with 50 grams of glucose is not only indicative of the very high suspicion of gestational diabetes, but can also help establish the prognosis in the future change in the glucose metabolism in gestational diabetes. Thank you very much for your attention.
Thank you so much for your interesting presentation. Dear colleagues, maybe you have some questions? Yes, please.
Hi, thank you. This was a really nice study. I was wondering, how do you think that the results of your study could impact the everyday clinical practice? Because gestational diabetes by itself is predictive, is a strong predictive factor of diabetes in the future. So what would this test change
Oh, yes, thank you for the question. Yes, it's very important. We surprise us these results. We think to find any other results when related to the impaired glucose tolerance after the birth, and surprised with the only when they test 50 grams. And in some hospital, like the USA, like in Spain too, we use this proof for discriminate diabetes gestational. If we have 180 milligrams after 50 grams, it's in some cases not needed to make an HOG. That is not now standardization, but that is very important. Perhaps in the future, try to show is this proof could be to discriminate better the patients with diabetes gestational.
Yes, but all the group, even with a nice response to the 70 grams, to the 50 grams,
75 grams,
they're
yes.
all high risk group. So you cannot leave the others one. You know.
I agree. Perhaps in Spain we don't make 75 milligrams test, but I think with this with this result is better. Perhaps this make it's more sensitive, it's more predictive. That's right. That's right.
Okay.
More questions? No questions. Thank you so much.
Thank you.
And next presentation?
Yeah. Sorry. Next presentation, please. Dr. Polina Popova, placental lactogen, placental growth factor, insulin resistance, and early pregnancy and risk of gestational diabetes. You have 10 minutes. Thank you.
Dear colleagues, I'm representing the Almazy Federal Northwest Medical Research Center from St. Petersburg. It's the picture of our center. Gestational diabetes mellitus is the most common complication of pregnancy and is defined as diabetes first recognized during pregnancy that is not overt diabetes. GDM can cause significant long-term and short-term complications of pregnancy to mother and child. Short-term complications include macrosomia and linked to macrosomia increased risk of birth injury and stillbirth. For mother, it is a higher rate of preeclampsia and a higher cesarean section rate. Both women with GDM and their children have increased risk of type 2 diabetes later in life due to epigenetic changes due to maternal diabetes can cause metabolic disease in the offspring and thus transmit the adverse environment to further generation. That's why it is important to find early biomarkers of GDM to diagnose it early and ideally to prevent it. During the course of pregnancy, hormones such as lactogen, placental lactogen, and progesterone are secreted by placenta to shift macronutrients from fetus, from mother to fetus, and to prevent low glycemic levels due to resistance to the action of insulin. Usually, maternal pancreatic islets increase insulin secretion according to the increased demands, but if it doesn't happen, if beta cells don't adopt to increased insulin demands, then glucose level rises. The major placental hormone implicated in the insulin resistance in pregnancy is human placental lactogen. It is secreted as early by placenta as early as starting from the 6 weeks of pregnancy, and its level increases up to 30-fold throughout pregnancy and induces insulin resistance. Another important placental protein involved in the pathogenesis of insulin resistance is placental growth factor. Its main role is regulation of placental vascular development, and it is a first trimester biomarker for preeclampsia and birth weight deviations, but also there are some data that it is associated with GDM development, and we found one recent article showing association of the first trimester level of placental growth factor with GDM development. So the aim of the study was to compare the level of placental lactogen, placental growth factor, and homeostasis model assessment score in early pregnancy among women diagnosed with and without GDM months later. It was a nested case control study in prospective cohort of pregnant women. The participants of the study came to our center before the 14th weeks of pregnancy, and their blood was sampled and stored for further biochemical analysis. Oral glucose tolerance test was performed after the 24th week of gestation. GDM was diagnosed according to the recommendations of International Associations of Diabetes in Pregnancy Study Groups. Russian Endocrine Society also recommends the same diagnostic criteria for GDM. We identified 78 GDM cases, and 95 unaffected persons were randomly selected as a control group. Statistical analysis included students t-test, logistic regression, and persons correlation. This slide shows the basal characteristics of the groups. Women with GDM were older, had higher first trimester BMI, and higher waist girth, and they presented with hypertension before pregnancy more often. Nevertheless, there was no difference between the groups in the incidence of family history of diabetes and impaired glucose tolerance before pregnancy. This table shows the biochemical characteristics of the groups before the 14th week of gestation. As you see, there was no difference in the level of placental lactogen and PLGF, but we found a significant difference in the level of insulin and HOMA insulin resistance score. There was also some difference in the level of fasting plasma glucose, cholesterol, and triglycerides, but the difference was not significant concerning these parameters. It didn't reach statistical significance. Correlation analysis revealed that HOMA insulin resistance score was positively associated with the development of GDM, and the association retained under a multivariable analysis controlling for age and BMI. And the maternal placental lactogen and PLGF were not related to the results neither to OGTT nor HOMA insulin resistance score or neonatal anthropometry. In conclusion, serum concentrations of placental lactogen and placental growth factor in pregnant women before the 14th week of gestation were not associated with homeostasis model assessment score and later development of gestational diabetes. But we found that higher HOMA insulin resistance score in early pregnancy is significantly associated with an elevated risk for GDM. Thank you for attention.
Thank you very much. Any questions? No, I have one question. Could you please roll back to your slide when you show group characteristics?
I would like, but
Wouldn't help.
I'm sorry.
Нам нужно отмотать слайды назад. Yes, this slide. Can you answer why? Maybe I'm wrong, but this slide shows that groups was differ in age.
Yes, it's true. It's true because control group was randomly selected. It was not matched to GDM patients, and it's not surprising that women with GDM usually they advanced age and higher BMI are known risk factors for GDM, so it's not surprising that they were different.
Do you think this not similarity, can it affect your results, or it's not important for this study?
If we had positive results concerning PLGF and placental lactogen, in this case, I would doubt what does matter, the age and BMI or these changes in hormones. But as I have mainly negative results, I think in this situation it doesn't matter.
Thank you.
Thank you.
Any questions more? Well, thank you very much.
Okay, our next speaker with a presentation about implementation of mobile diary app into a clinical practice of gestational diabetes treatment, Dr. Evgeny Pustozerov. You have 10 minutes. Thank you.
Okay, so a good day once again. I'm not yet a doctor, actually. But I would like to present to you some brief presentation on the research that is ongoing at Federal Mazov Medical Center, and about one part of it, which is the topic of today's lecture, about the implementation of mobile health technologies into healthcare in this case. So when we talk about this implementation of mobile health technologies, we of course first think about benefits we can get from it. So the benefits are, of course, strongly tied with the shortcomings and the problems we have up to date. So talking about this particular case of gestational diabetes treatment, we of course understand the importance of correct, proper diet management during this course of studies and course of treatment. But when we talk about this traditional paper diaries where when patients write their records, write on the paper about the blood glucose levels, maybe food, there are lots of problems we have. Not only problems with the organization and analysis of these records, but also the problems of collecting these records, and of course a motivation for the patient to keep these records. And the second point is, of course, when we implement the remote monitoring system, we can obtain a better interaction in between patient and doctor, which is very important. So summing up all of these problems, we came up with the goal to develop a proper application for the remote monitoring of gestational diabetes patients. And to fulfill this goal, we came up with the objective to start from scratch, to start from the requirements to then applications, and describing the structure, describing what kind of data you want to monitor and to take on, then to develop the software, and of course to maintain it working. And so we came up with a group of physicians to make some requirements for the system, and here are there. So first of all, it should be mobile. It should be on the mobile devices so patient can keep track on records wherever he is. And then it should be easy to use without any proper computer knowledge and mobile phones knowledge. It should be useful. It shouldn't be boring to take records for improve the motivation for a patient, which is very important. And it should, of course, export the data and send it remotely to physician in the form that is convenient and in the form that is easy for further analysis. So here's the type of records that we would like to keep track on. Of course, blood glucose levels, insulin injections, if any, food intakes, which is the most crucial part and one of the most complicated, physical activity, sleep, ketonuria levels. So listen, you see how they look like, this track of these records. And so then I took these requirements and I developed an application, first of all, for Android devices like smartphones and tablets. And after I made it, and also desktop application for laptops and so on. So that was a kind of recent photo, actually. And talking about tracking the food records, one crucial part is the food database that we use inside of the application. So we developed it from scratch. We combined lots of different sources with lots of information on food that then patients can take and from the database and to keep records. So I'll show two small use cases how it looks like. So for example, patients wants to add a record. He puts the button, what kind of food intake is that? For example, a dinner, then adds an item to this food intake. For example, potatoes, how much of grams are there? And then they are collected in one record and it's safe. So it takes really less than 1 minute to perceive these records. Another example is how to work with the database. So a patient improves, for example, he searches for the bread, looks for the options, takes one. He can take more detailed information on every record and also can add some more. And here's how the data is exported. So it is being sent to the physician remotely and as an XLS file. So one spreadsheet with lots of lists. And here one is with the blood glucose levels, there are insulin, food, physical activity, and so on all together. And because the study is still ongoing, we have patients enrolling every week, this week, for example, and we didn't make any statistical analysis or some analysis, but here are some preliminary results. So it used to be 85 patients who received these applications and start working with that. Today it's more than 100. Lots of measurements, lots of records about food, lots of material to analyze and to compare with other clinical analysis and so on. Here are the average numbers you see. And as for the food records, we have found a problem with underreporting when not all the food is included, that people actually forgot to keep records and so on, but we have found a way to deal with that and so on. So hopefully by the end of the studies, we'll get the good numbers, will help this application. So a few words is that using this application is also not only good from physician perspective, that's easy to use, but also that we can collect the data that otherwise we wouldn't collect in any case. And just a few words about the future proposals. First of all, we have a server that collects the data together. Also, it might be useful to use this in further development. And we also use this application to track food records during continuous blood glucose monitoring. So no results by now, but we have also work in this direction. So thank you very much for your attention.
Thank you very much. Any questions? Yes, please.
Thank you very much. Very interesting, and especially nice that really young, especially students, are coming here with good works, really good English. That's great. That's what ICE is for. And I really appreciate this topic about all the applications. I think it's very in stream now and popular and very convenient for users. But why did you specifically choose gestational diabetes? Don't you think that kind of application could be good for any type of diabetic patients or obese patients?
Well, yes, it could be modified of course, this application. But there are some crucial points that actually are related especially to gestational diabetes. For example, when we export the data, we show not only blood glucose levels, but also pregnancy week at the moment. And then we analyze data. When we analyze data, we also use this information about the pregnancy going to compare with. So it's dedicated to gestational diabetes, but of course it can be modified in the way that it can be used for other types of diabetes afterwards.
Thank you. More questions?
And is there good compliance from the pregnant, or what are the results of the compliance to the usage of this kind of application?
Compliance? So as you see, that was number average.
Do they fill all the fields and all the required? Do they give you enough information? And how many pregnants use this? All the pregnants that you have in your clinic, or just part of them?
Well, those who would like to, but usually they agreed quite okay if they have appropriate device and at least some motivation for that. And as for tracking, it really differs. Some patients can do that only for a week, and they quit afterwards, and some do that after the end of pregnancy, so after the last day. So it's very different. There used to be a slide. The average number of days of monitoring was 49. But there was the minimal number is two days only, and the maximum numbers is, well, of course, works only if we started this early out. It was like 100 days of monitoring almost.
Do they think that's convenient?
Yes, we are actually running the survey now, email survey about your convenience. There is a questionnaire with 10 questions. And I also didn't analyze the results yet, but soon I will be able to answer this question.
Thank you very much.
One more question.
Thank you for your great and very emotional presentation. And my short question is about food intake part. And as you showed us that this part, when a patient, add a meal, he counts how many grams this meal was. So is it just this option? Because mostly people, they have no idea how many grams they have. So is it possible to add like how many spoons or pieces? What do you think about it? Why this approach?
Used to be. We used to have this other option to write in portions. But then we realized that the portion differs so much in between patients, and even spoons are so different that for more, of course, it's not always convenient enough, but for more precision, it's better to ask patients to at least estimate in grams.
Okay, thank you.
Thank you. Very nice talk. So, is there an incentive for the ladies to fill it in? Do they get something back from it, or?
Yes, they have this interaction with physician. So there is the email is automatically sent from the application with the table, and the physician receives this table and writes an answer right on email. So
they get direct advice what to.
Yes,
on
for
the
example,
amount of insulin and things
the really
like
high blood glucose levels, and there is a reason why it was high like this.
Oh, that's really nice. Yeah.
So thank you very much. We should move on to the last presentation.
Is clinical course of gestational diabetes mellitus and pregnancy outcomes in women with GDM in relation to the method and term of diagnostic. Irina Bunak, you have 10 minutes maximum. Thank you.
Okay. Good morning. I'm from Moscow Regional Research and Clinical Institute. My name is Irina Bunak, and I want to present to you my study about clinical course of gestational diabetes mellitus and pregnancy outcomes in women with GDM in relation to the method and the term of diagnostic. First of all, let me remind you about a new criteria of diagnostic of gestational diabetes mellitus. They based on HAPO study results. They proposed to use by International Association of Diabetes in Pregnancy Study Group, approved by World Health Organization, except in Russia, and effects to the prevalence of GDM. I want to pick out what is new. All pregnant women are exempt for GDM. Cut point for fasting glucose is decreased to 5.1 millimole per liter. It was added one more measurement of plasma glucose after 1 hour in OGTT. Abnormal glucose level after 2 hours was increased up to 8.5 millimole per liter. And only one abnormal value of glucose is sufficient to make the diagnosis GDM, fasting level or any points of OGTT. The aim of our survey was to study clinical course of GDM and pregnancy outcomes depending on terms and methods of diagnosis GDM. 192 pregnant women was included into our study. The average age was 28.4 years. Average body weight was 68.8, and average BMI was 25.3. All pregnant women was divided into 3 groups. First group includes 86 pregnant women with high fasting glucose level before 20th week of pregnancy. The second group included 43 pregnant women with hyperglycemia in OGTT after 20th week of pregnancy. And third group consists of 63 pregnant women without GDM. It was a control group. Some basic information about the groups. In this slide, you can see the characteristic of groups. Pregnant women with GDM were older than non-GDM women and had significantly higher body weight than non-GDM women. There was one difference in age, BMI, between first and second groups. You can see the result of first screening for GDM, fasting glucose level, and term of screening weeks between first, second, and third group. There is the results of OGTT. There was no significant difference in term of OGTT between groups. Now I want to tell some words about treatment. This is algorithm of treatment for pregnant women with GDM. We use diet therapy during 2 weeks and CMBG for 4 times a day. If glycemic targets are reached, we continue our diet therapy and CMBG for 4 times a day. And if glycemic targets aren't reached, we have to initiate the treatment by insulin and CMBG for 7 times a day. Not all women were compliant for the treatment. The proportion of compliant women was the same in first and second group, and it was about 35%. We compare the groups with different type of treatment. Pregnant women from both groups who needed insulin were significantly older and had higher BMI compared with women on diet. The number of women treated by insulin was higher in second group. We compare insulin-treated women from first and second group. Women who was treated by insulin in third group were younger but had higher BMI compared with the second group. Outcomes of pregnancy. We compare outcomes of pregnancy in compliant and non-compliant women with GDM. The frequency of macrosomia and summary adverse pregnancy outcomes such as hypoglycemia, neonatal jaundice, clavicle fracture, asphyxia was high in non-compliant women with GDM compared with compliant women. Then we compare outcomes of pregnancy in non-compliant women with GDM and healthy women of the third group. There was a significant difference in delivery term and summary severe adverse outcomes such as macrosomia, preterm delivery, and stillbirth between non-compliant and third group. And then we compare outcomes of pregnancy in compliant women with GDM and in healthy women of third group. And there was no significant differences in delivery terms, macrosomia, and other adverse pregnancy outcomes in these groups. So we can conclude that pregnant women with GDM diagnosed on base of high fasting glucose level need insulin less frequently. And pregnancy outcomes in women with GDM depend on compliance rather than on terms or methods of diagnosis. Thank you for your attention.
Thank you very much. Thank you very much. We have time only for one question. Any question? So, thank you very much. Oh, yeah, one question, please.
Thank you for an interesting presentation. What glycemic targets do you use, or what? How do you decide about treatment targets? Are they reached or not?
I use targets which are based on consensus of gestational diabetes in our country, and it was 5.1 millimole per liter for fasting glucose level, and less than 7.0 millimole per liter after 1 hour.
I see.
After
I see. And how many abnormal values is enough to prescribe insulin?
One more.
How many abnormal values you look for to start insulin?
More than 2 abnormal for the week, for 1 week.
Actually, in my opinion, it's almost impossible to force women to start insulin if she has 5.1 twice a week and nothing else.
No.
In my practice, it's very rare that women quickly agree to start insulin with these targets.
It's not a lot of women. I show you that compliance was low.
Yes,
and
I agree with you.
Not a lot of women can show me these results.
And if you start insulin in such borderline glucose values, what are the middle doses of insulin you use?
It is a small doses. It was about 0.5 or 1 international
units.
What is 4 kilograms.
So very small doses, maybe you just make them think more about diet when they have to use insulin in such small doses.
Maybe.
Thank you.
So, thank you so much. Our scientific session is finished, and unfortunately we have no time for a break, and we should start the next session right now. Thank you very much, and have a nice day.
So, would you like to present
Adam?
the first one?
Okay, so an old friend of ours, Adam Chijing from Poland.
Hello everyone. I didn't check my slides, so I hope that they are okay. I won't be too long because this is kind of preliminary data that we obtained with our Widen team. We included psychologists and informatics to develop software to estimate the facial emotion expression and recognition in patients with polycystic ovary syndrome. So what is facial emotion expression recognition? This is, of course, ability to recognize someone's emotions, someone's feelings, based on just on his face and on her mimics in this case. And of course, the arrangement of this ability is one of the main features for psychopathology and is important factor for psychiatric or psychological disorders. Why I was interested in this kind of study? First, I did some studies a few years ago in Turner syndrome patients, and those patients suffer from alexithymia, so they have problem. These women has problem with recognizing emotions in other people. And when we look to the literature, there are also some data which says that sex hormones can influence significantly the facial emotion recognition, especially estradiol and progesterone. Progesterone is related, for example, with diminished abilities or decreased abilities to recognize someone's emotion. Okay, so the aim of the study is obvious. I think we wanted to check how the woman with PCOS recognize emotion expression. So far, as I said, this is preliminary data, and for this kind of studies, the groups are too small to have significant results, in my opinion. But so far, we have almost 60 women with PCOS group and matched by age with controls, which are of half of this number, let's say. Okay, we developed special software with help from informatics. And this software is called Emotiface, and it's based on Windows-operated portable devices. And it shows faces. I'll show you in a moment. And we also included Eysenck personality questionnaire. And that was a requirement of psychologists because patient with some disorders of personality has problem with emotional recognition. Okay, that's how it looks. It is, this one of course shows anger, and patients needs to check which emotion does the face shows. As you see, we examined set of 8 emotions, and some are presented here. This set of faces was taken from the USA, from NIMS team set. It is validated by psychologists in clinical setting, and it includes 672 pictures of mixed race, ethnicity, and sex as well. Okay, we are endocrinologists, so we did some endocrinological studies as well, FSH, LH, estradiol, androgens, and thyroid status was included to this analysis. And for emotion recognition, so far we have accuracy rate, so this is the number of correct answers, and time required to recognize emotion, because the software measures it as well. So, results. As you see, we had some differences, especially regarding recognizing surprised facial emotion and calm. The calm and neutral are very similar, and everyone has problem with distinguishing them. But for both those emotions, patients with PCOS had worse results. Regarding the time required to interpret the face emotion, PCOS patients needed more time to recognize angry faces. Okay, we performed short correlation analysis, and statistically we found nothing, but there was tendency, was 0.07 between estradiol concentration and time required to recognize happiness. Okay, so this is first such a study about emotion recognition in PCOS patients, and it seems that we will find something, but we need more time and more patience. Thank you.
Well, thank you so much. This was really interesting. Are there any questions from the audience? Yes, Anneke, please.
I hear you.
So if you have more estradiol, is it, so do you need less time or more time to recognize happiness?
More positive correlation.
So you need more time to recognize happiness?
Yes. As I said, there are some data about estradiol and emotion, so it can be true.
So does that mean that you're less happy also when you have?
No, it's only interpretation of other emotions, so yeah. I don't think so. I was hoping that we'll find something with anger, for example, because androgens influence, of course, male type behavior and anger and so on. But so far, we missed with this.
Very interesting. So I'm looking forward to the other results.
Thank you.
Okay.
Can I ask if the subjects, all the subjects, if they knew that the time to answer was recorded, and if there are any differences regarding the time to answer between the groups in general? Not.
Patients didn't know. I told them that you have your time, and there is no time limit, no correct answers, so they do it as they feel. They were in calm position. It takes about 40 minutes to undergo the personality test and facial testing. So there were some differences regarding
because maybe in the beginning they would spend more time to some facial expressions, and then as the time went by, they would be more.
Yeah, good idea. It's worth to check how do they deal with first phases. But I think this is very simple software, so.
It's the same. The phases are with the same turn in all the tests, or they are rapidly selected?
No, they are randomly selected. From 600, only 80 are projected
okay.
in each patient.
Can I ask a question? Did you maybe correlate the level of their emotional status of the day when they were filling out the questionnaire? For example, if because of the mood swings that sometimes females have?
Yes, but maybe they are influenced by hormones, so that is the idea. We didn't ask about it because
maybe in the different parts of menstrual cycles, like it would be interesting to see if it's.
Yes, there are some data which shows that progesterone is emotionally blinding hormone. And all the patients were in the same phase between 8th and 10th day of the cycle.
Okay, thank you.
Okay, thank you.
Okay, so we can move on.
Okay, thank you. So, our next speaker is Sofia Grigorian, and she's from Russia, and she's going to talk about pregnancy and delivery associated with Cushing's disease.
Good afternoon. I'm delighted to be here today, and also I'm not a real doctor yet. I'm graduating the university this year, but I'm going to be talking about endogenous hypocortisolism and gestation. And just to remind you that it is Cushing disease which makes up the largest part of all endogenous hypocortisolism cases. And probably pregnancy it's uncommon situation, but hypocortisolism during the gestation also it's a physiological condition, and there is no any maybe specific symptoms, and that is why it's rather hard to a doctor to diagnose such situation. But if we will miss it, have a look how many complications may happen. And according to the literature, the most common are intrauterine growth retardation and preterm delivery and preeclampsia and gestation diabetes, and also lots of others. And due to the seriousness of such situation, we decided to investigate this case in great details. And what we did, yes, this slide will give you the general overview of the research we did. Despite of diagnostic problems, we found 22 such patients, and we divided them into two groups. The first group who had Cushing disease before pregnancy, it's 13 patients, and the second group who got ill with Cushing disease just after delivery. So the second group, it's 9 patients, and this group is important for us because we think that in such cases, pregnancy served as a trigger for Cushing disease. And what we did, we communicated with patients, analyzed their medical documentation, and examined some of them, what for? To evaluate pregnancy complications, delivery complications, health status, postpartum health status of our patients and their children, and of course, progression of Cushing disease. So first comes pregnancy. The question is how often the complications during the pregnancy was observed. As you can see, rather often, and the most common were edema, proteinuria, and hypertension. And also, 92% was observed among first group, among women who had Cushing disease before pregnancy. delivery, also complications rate during delivery is also rather high, and similar 100% was observed among the first group. And the most common complications were double entanglement umbilical cord and fetal hypoxia, and also bleeding. This leads me to my next point, which is how delivery affect of Cushing disease. Unfortunately, the progression of Cushing disease was observed in mostly cases, and also recurrence took place in 50% among women who were in remission before pregnancy. But now more optimistic data, the children in mostly cases were particularly healthy. And finally, very important, Cushing, after postpartum treatment, the remission was observed in 100%. And if we compare our patients with the women who had Cushing disease but didn't get pregnant, but they were treated by neurosurgery, we also can see that remission was observed in 69 till 92%. So what I'm saying is there is no significant difference. And to conclude, to summarize all this information, first what we need to understand that gestation and delivery during active Cushing disease is not safe, of course, because of very high complications rate and unclear clinical symptoms. But if it occurs that our patient got pregnancy, what we need to consider? We need to consider the duration of Cushing disease. If it is long ago, we need to be very attentive. And if it's newly acquired, so the prognosis is much better. And so if in other situation, if we have a patient with Cushing disease, which was long ago, and now it's remission and everything is okay, which probability of the recurrence is it? So according to our research is rather big, it's 15%. But children in mostly cases are particularly healthy, and remission after postpartum treatment isn't different from the patients with Cushing disease who didn't got pregnant. So thank you for your attention. I hope that this information will help you.
Okay, thank you, Sophia, for your nice presentation and time-efficient one, especially for a graduate medical student. Before opening for questions, I would like to have 2 comments regarding the definition. So, because your title has to do with pregnancy and delivery, did you include also women who miscarried, or only those who delivered?
We include only those who delivered because it was easier for us to find women who had already delivered children.
So you should say it's the title.
Yes, because we take them from database.
Okay.
And it's easier to find who had already delivered.
And my other question, again regarding the definition, is how many years, because the sample looks a bit heterogeneous, so because you have women that have already had Cushing disease and other that they had Cushing that they developed Cushing disease later. So how many years are there the time interval between pregnancy and Cushing disease?
It's 1 year.
Oh, it's 1 year.
It's, in mostly cases, it's 1 or 3 months when clinical start after delivery. I mean.
Okay. So it's pre-existing. It was existing in pregnancy.
Yes.
Yeah. Okay. So any questions from the audience? Not any other questions from the audience.
Can I just ask you, what was the time frame that you've collected? You had collected the 22 patients between for time? How many?
It was database based.
Yeah, but in what time?
For time, we took
between which years?
We took patients from database for the last 10 years.
10 years.
10 years.
Thank you.
Yeah. It's extremely rare.
Yeah, I had 2 patients. Well, I mean, one was really challenging. She would get Cushing every time she would get pregnant, And I have to say that she is the most severe Cushing that I've ever had. Like her stria were all over her body, and she developed it during her pregnancy.
We can discuss it.
Yeah, and it was really challenging to deliver her, and every time she tried to stay pregnant 2 times now, but she would develop Cushing's, and then she would decide not to go with pregnancy.
Okay, thank you, Sophia.
Okay, so we move on to our next speaker. It's Sara De Vincentis from Italy.
Good morning. I'm going to present you our study about hormonal changes in female volleyball players. Let me spend a few words about the background to introduce you this topic. In literature, we can find many studies that have evaluated the hormonal response to an acute physical effort, but very few investigated the hormonal changes in an extended period of time. At the same time, few studies involved female participants, and moreover, in these studies, several authors proposed to use testosterone-cortisol ratio to assess a state of overreach, to assess catabolic and anabolic balance. In particular, it seems that a cutoff decrease of 30% of this ratio could be a useful cutoff to assess a state of overreach in athletes. So with this in mind, the aim of our study was to evaluate the hormonal changes during an annual volleyball female regular season in players. Considering the study design, we performed a longitudinal retrospective observational studies. We enrolled 28 female volleyball players belonging to the same team. So no inclusion and no exclusion criteria were provided, and all players were enrolled in the study. Their mean age was about 23 years old. In the blue box on your left, you can see the weekly planning of our players, and in particular, they underwent 5 training days a week with free Monday, and Sunday was reserved to the competition match. Our trial lasted 8 months from September to May, and in this period of time, each player underwent 4 visits. Visit 1 was performed in September, when at the beginning of the training. Visit 2 was performed in November, when the championship began. Visit 3 was performed at the middle of the season in January. And finally, at the end of the championship and the regular season, we performed the last visit, visit 4. For each visit, we collected the blood sample in order to assess biochemical and hormonal parameters. In particular, we measured with immunoenzymatic assay GH, IGF-1, TSH and thyroxine, cortisol, testosterone estradiol, and gonadotropins. Just to specify, we collected the blood samples on a Monday, so after 36 period of rest, in order that the acute effort of the competition match on Sunday couldn't interfere with our measurements. Going to result, considering the GH pathway, we found that the mean value of GH was about 5 nanogram milliliters. That is higher than the upper limit of the normal range of our lab. In particular, we found that 5 athletes at the visit 1, the first visit, presented a value of GH higher than the normal range. And this result corresponded to a percentage of 18% that is higher than the percentage in normal population. Together with this result, we found that mean value of IGF-1 was at 18th centile adjusted for sex and age. Considering overall assessment, overall hormonal assessment, neither GH or IGF-1 or TSH showed any statistical significantly changes among visits, but testosterone and cortisol, as you can see, statistically changed among visits during the year. In particular, testosterone In particular, testosterone showed the highest values at visit 2 and visit 4 than the visit 1 and visit 3. So testosterone had the highest value at the beginning of the regular season, at the beginning of the championship. Similarly, also cortisol had the highest value at visit 2 at the beginning of the championship 2 than in the other visit. But testosterone had a fluctuation during the year, while cortisol had a slight decrease during until the end of the year. And taken together, testosterone and cortisol, if we consider the ratio, didn't show any statistical differences during the year, but you can see that from visit 1 to visit 3, there is a decrease of about 30% of our testosterone-cortisol ratio that corresponded to the 30% cutoff that we said at the beginning of the presentation. So we can see that our athletes maybe had underwent a condition of overreach during the year. So, in conclusion, we confirm that the continuative competitive sport influences endocrine homeostasis. In particular, testosterone and cortisol showed significant changes. And we suggest that the testosterone-cortisol ratio could be a useful index in order to assess a condition of overreach in women players too. Thank you for your attention, and this is the last slide.
Are there any questions from the audience? Yeah, Sika.
I have one question. What is the rationale of suggesting this testosterone to cortisol ratio as preference?
Because we can assess the anabolic and catabolic balance. Anabolic of testosterone, testosterone had anabolic actions, and the catabolic of cortisol. So we can.
So you these fluctuations of cortisol and testosterone throughout the season, you attribute them to.
When the ratio decreases, it means that cortisol is
yes.
increase more than testosterone.
From a psychoneuroendocrinology point of view, I would think that cortisol.
Mm-hmm.
Cortisol is also a marker of stress. And,
yes,
and we know that stress might be, the waiting period stress might be higher than the stress of performance itself. So if I'm correct with your data, your athletes had really high stress at the beginning of the season, and then as the season,
and then it
so it declined. So maybe cortisol could be attributed to that, to the stress. Psychological
maybe
stress.
Because there is an adaptation to the organism, to the stress.
No, maybe it's because of the waiting stress. You know, the waiting period stress, which is really high, and it has been demonstrated in various areas. So maybe cortisol is because of that. For testosterone, I don't have an answer. Maybe for testosterone is. Maybe there are two different things going on.
Yes.
Yeah.
Did you, were they all the menstrual cycles of these women, because they're athletes?
Did you?
How did the menstrual cycles?
We are collecting data about it, because there's a volleyball team, and
yes.
We are trying to collect data about physical
yes,
cycles.
It's dependable on the time of the cycle,
yes,
the time when you collect
it's
hormones. I understand you reproduced the study which was done on the males previously, yes. Right? And you've decided for Tuesday as a day to collect the blood samples for each of them, right?
Yes.
But I'm wondering if the Tuesday, I understand the rationale, but the time of the menstrual cycle is very important.
It could be very important for us to know the
and the
period
gonadotropes
yes,
especially.
Yes, I know.
Okay. Any other question? Please.
I can't hear.
If you have a control group of women,
No, no.
Like in
not yet.
amateurs and professionals?
Yeah.
Because maybe also there might also be an influence of cortisol during the year, also temperature driven.
Yes, there are many factors that would interfere with the measurement.
But
Also, assay, immunoenzymatic assay is not the best to evaluate the testosterone and cortisol. We know that, and so we are trying to.
It would be nice to have a control group so you can correct for other factors that are not exercise.
Yeah.
Just one comment. I want to say that it's very important, sports in endocrinology, and we've tried to contact someone who is involved in as a young endocrinologist in sports, and it was very difficult.
Yeah.
So it's very nice that you are actually doing it.
Yeah.
Okay. So we can move on. Thank you.
Thank you.
So our next speaker is Tomas Kurakovas, and he's from Lithuania, and he's going to talk about the comparison of the sexuality of 26 to 36-year-old Lithuanian healthy and type 1 diabetic males with older than 40 years men's sexuality of 8 European countries. Okay.
Thank you. Thank you for organizing committee and scientific committee who allowed me to present my presentation here. So let's start. What is sexuality? Sexuality is feelings and attractions what everyone feels towards the other. It is like this aura radiating from us, and it's quite difficult to evaluate. So several years ago, here was one big assessment made by European Male Aging Sexual Function Questionnaire, and was participated 8 European countries, and more than 3,000 people were assessed. And we decided that maybe we can translate this questionnaire to our national language, Lithuanian, what we made. And after we translate it also to Russian and Polish languages, it's one of the pages from it. I translated to the Russian one. So methods. We took already evaluated 80 healthy people for reproduction health, but their sexual aspects they didn't check already. And we took 122 patients with type 1 diabetes. We gave them European Male Aging Study Sexual Function Questionnaire, which is evaluating several aspects like oral sexual function, masturbation, sexual function distress, and so on. So the results were overall sexual function between healthy one and EMAS group. It's EMAS group which already published results from this big study, and the type 1 diabetic patients with different duration of the disease. And the results were of overall sexual function that healthy population had the non-significant result with 40-49 years old and with first 10 years of duration of the disease. The masturbation activity, yes, Lithuanians masturbate more. And it was the highest aspect. And the sexual function distress, so lowest it is, and better. And here is, we found that sexual function distress was the highest independent on the duration of the diabetes. And we thought maybe it's mostly due to psychological problems. Sexual function changes during the last years were similar like with overall sexual function. The results with two groups were also non-significant statistically, and with 10 years, first 10 years of duration of diabetes. And you can see that gradually with age, it is decreasing. And our conclusion that sexuality of 26, 36 years old, males are similar with 40, 49 years old, and maybe it is plateau of male sexuality from 26 to 49 years old. And what about the diabetics? We had a lot of patients who came to us sadly because they read in internet that they will be very fast impotent. And we said that it's not true, and gradually your impotence will be. And if you will not be treating, you will have more chance to have it. And their sexuality was similar with 50, 59 years old, and we concluded that it's maybe eldering disease, and it can be would be used as a marker of senescence. So it's our team, it's our hospital, and I want to mention that we are planning to publish one abstract in Russian journal Therapевтический архив with Russian scientists, and now we are waiting for answer from them. And it's our city, and thank you for attention.
Okay, thank you for your nice presentation and the inspired introduction to the world of sexuality. So, are there any questions from the audience? Anek. No, you can.
So there was, for the sexual distress, you had a very large distribution. Did you correct for the regulation of the diabetes? So did you check for how, if the diabetes was regulated well or not? Because I can imagine that if you're not regulated well, there might be more problems than when you're not very good regulated, or when your glucoses are not very good regulated.
I think it was, it depends on patient. Moreover, they regulated, more or less.
Yeah, so but did you correct for the glucose levels, for example, or HbA1c?
Yeah, of course.
So, but did you see correlation between sexual function and HbA1c?
No, it's in normal, in controlled levels, and we thought that it's mostly due to psychological problems, and we sent our patient to a psychologist, and now we are waiting simply for results.
I'm not sure you understand what I think.
I understand the question?
Yeah, Anneke is asking if you know the glycosylated hemoglobin concentrations of your patients. So if you know that those who are treated better, they do better or not?
No, I don't know
You don't know, you don't
levels,
have the data.
Because we took results from our registry of diabetics, and we simply
looked at the diagnosis and not at the way they were regulated, at the clinical
Okay, I
studies.
think we should do it. Good question.
Yeah.
Thank you.
Any other question? Yeah, in the front. Oh, yeah.
For this nice report, I was just like wanted to ask the same question like was just asked now. If we're talking about the last complication of diabetes, what was the main topic of this investigation? You wanted to compare this question of sexuality among the people you've changed for the group. The main case you wanted to check the last cases, the last complication of diabetes, or you were talking generally in main thing about not about psychological problems. What is the main thing in this investigation? Have you had a group of patients with like two groups, general group with physical problems and how to say this? And psychological problem and psychological aspect of this problem.
We are first who are assessing sexuality in Lithuania, so we simply give to healthy population, to diabetics.
And so you just compare it without
we just
taking the aspect
results.
of the last complication of diabetes. So
because our country is quite religious, and our males are very closed, and it's very, very private questions for them.
Okay, thank you.
Okay. Any other question? Just for two technical comments. You showed us the questionnaires, but did you go through formal translation with back, forth, and
Yes, I made all this.
And then you validate.
Yes, and validation.
Okay.
In every language.
Okay. And the next technical comment is that when we saw the results of your study at the graphs, you had 4 groups of diabetic patients according to their age, and only 1 group of the control, so of control men. So what would better for us to see would be a direct comparison of all the diabetic men with all control men, and then
here was we took the same age diabetics. The age of diabetics was the same age like healthy population, 26, 36 years, and we divided to different duration of the disease.
To different, but would be.
Here was one last slide where is all patients.
But also it would be better to have 1 group of diabetic patients and 1 group of controlled direct comparisons, and then you compare the diabetic patients according to their durations, but only to diabetic patients.
Okay, okay, I will do it. Okay.
Okay. So thank you.
Thank you
for your presentation.
Okay, so I can tell that from the title that our next speaker also comes from Modena and Professor Simone's group, and who was our host last year. So Elisa Magnani, the floor is yours.
So good morning. Today I will present to you the results of our study which evaluated the effect of vardenafil on adrenal and testicular steroidogenesis. This study was initially designed to study something else, to study the endothelial health parameters in diabetic men. And what we found at the end of the study was that after 6 months of chronic treatment with vardenafil, we had a reduction of the markers of inflammation, but even an improve in the levels of testosterone in a subgroup of hypogonadal men, even if the underlying mechanism is still unknown. What we know is that phosphodiesterase 5 inhibitors are able to increase the intracellular levels of cyclic EMP and cyclic GMP. And considering that these two second messengers are essential for the function and bioavailability of the enzymes involved in the steroidogenic pathways, a positive effect of vardenafil on steroidogenesis may be expected. So that's why we decided to continue the study and to investigate the effect of vardenafil on adrenal and testicular steroidogenesis using liquid chromatography tandem mass spectrometry, which is considered now the most accurate method for serum steroid assay. So this was a longitudinal, prospective, randomized, double-blind, placebo-controlled study, which had a duration of 1 year. We had the first 6 months of treatment phase, where patients received vardenafil 10 milligrams twice daily, or placebo in the study group and control group respectively, and other 6 months of follow-up phase. These are the inclusion and exclusion criteria, and I just want to draw your attention on the fact that all the patients were subjects with a recent diagnosis of diabetes, and that we don't have here the gonadal status of the patients because, as I said before, the study was designed to study the endothelial parameters. And And on the initial 54 patients enrolled randomized, only 20 patients in the study group and 22 in the control group completed the study. So only on these patients we made our per protocol analysis. Assuming that serum steroids are a reliable indirect marker of tissue steroidogenesis, we decided to study progesterone, 17-OH progesterone, androstenedione, and testosterone for study testicular steroidogenesis. Corticosterone as expression of zona glomerulosa, 11-desoxycortisol and cortisol as expression of zona fasciculata, and the hydroepiandrostenedione and the hydroepiandrostenedione sulfate as expression of zona reticularis. We divided the serum steroid on the main of their main origin, because we know that in the adrenal gland each area expresses different enzymes and cofactors and activates different steroidogenic pathways. So, to come to the results, we didn't find any significant differences in the testicular steroidogenesis and in zona fasciculata between study group and control group. While if we consider zona reticularis, we can see from this graph where the study group is represented from the white columns and the control group from the green ones. We can see here how the DL levels decrease rapidly in the first 2 weeks of treatment, but this only in the study group. So this is an effect that happens only in the study group. But the DL levels rise again at visit 8, so still under treatment. So this is a transient effect. And a possible explanation of this finding is in these two reactions, because P450C17 mediates both 17-alpha hydroxylase and 17-20-liase action. But in these two reactions, we have a different regulations. In particular, only in the second one, we have the cytochrome B5, which is an enhancer of the reaction because it mediates the electron transfer. We know from the literature that an increase of cyclic EMP causes an increase of the bioavailability of P450C17, but a decrease in the bioavailability of the cytochrome B5. So we can assume that an increase of the cyclic EMP levels due to the vardenafil treatment may decrease the 17-20 liase activity and so the DL levels. Why the effect is transient, we don't know. Probably because we study only the serum steroids, and probably in the adrenal gland happens something else. So maybe other pathways are activated to restore the DL levels. And in conclusion, and at the end, in zona glomerulosa, we saw that we had an increase in the corticosterone levels in both groups, so this wasn't an effect due to the vardenafil treatment, only in visit 2, 8, and 10, which were the only 3 visits where patients underwent a completed physical, andrological, and ultrasonographical evaluation. So we could speculate that this is a stress-related, a visit-related stress for the patient. We expected even an increase in cortisol levels in these 3 visits, but we didn't find it in this study. So, in conclusion, chronic phosphodiesterase 5 inhibitors administration may affect adrenal steroidogenesis in diabetic men, and the chronic treatment with vardenafil 20 mg daily seems to reduce their levels as a possible consequence of modulation of steroidogenic enzymes by tissue changes in cyclic GMP and or cyclic EMP availability. So, thank you for the attention.
Okay, are there any questions from the audience? Yeah. Well, this is a big work, really interesting. I remember Santi presented his work some years last year.
The first one.
Yeah.
So the one I show you in the first slide. Yeah, this was
right.
the
continuation of the study. Very nice.
Yeah.
I can have a very a really small detail, but it just because you said that this is a randomized trial that is not sponsored by any industry, and this is by itself, this is marvelous. I was wondering, how did you manufacture the placebo? Because it's supposed to be the same pill.
Yeah, the pill was, it seemed the same. Yeah, the patient...
Did you manufacture one for the purpose of the study, or...?
Yeah, our internal pharmacy.
Okay.
Yeah.
They did that?
Yeah.
Awesome.
Okay, no questions really.
Okay. Okay, thank you.
Thank you.
Really nice. So the next speaker is Anna Loktionova from Russia, and she's going to talk about mRNA analysis of genes responsible for idiopathic hypogonadotropic hypogonadism.
Good afternoon, dear colleagues, dear chairmen. First of all, I want to thank organizers of this meeting for the great opportunity to contact with the colleagues from different countries. So today I would like to present our research devoted to investigating mRNA expression of genes responsible for hypogonadotropic hypogonadism. Our research based on basis of Moscow Regional Research and Clinical Institute and Biological Faculty of Lomonosov Moscow State University. Firstly, I can talk about structure and function of hypothalamo-pituitary gonadal axis or reproductive axis. The initiation and maintenance of reproductive axis in human is the contingent upon the pulsatile secretion of gonadotropin-releasing hormone by hypothalamus. Due to the influence of gonadotropin-releasing hormone on pituitary, gonadotropin synthesis and release starts. Then gonadotropin's luteinizing hormone and follicular-stimulating hormone regulates synthesis of peripheral sex steroids. Now I would like to define the syndrome of hypogonadotropic hypogonadism, in particular congenital isolated hypogonadotropic hypogonadism. The syndrome defined by lack, partial or complete lack of pubertal development secondary to deficient GnRH-induced gonadotropin secretion. This syndrome characterized by low levels of sex steroids in the presence of low or inappropriately normal levels of gonadotropins with no anatomical lesions of reproductive axis and no other associated pituitary hormone deficiencies. It's important to focus on mechanisms of development of this syndrome, which involves mutations in many genes. Some of these genes are responsible for, some of these genes responsible for normal development and migration of GnRH neurons from the place of their origin in the nasal placoid to the place of their functioning in the hypothalamus. Another gene encodes proteins which are responsible for GnRH secretion or GnRH action. The majority of studies in the field of genetic of hypogonadotropic hypogonadism based on investigating and study genetic abnormalities in the patient with pubertal disorders or infertility. But we have point out that DNA impairment can be found just in 5–15% of such cases. So, due to this fact, we decided to use a different approach, determination of mRNA expression of reproductive responsible genes. In particular, we concentrated on genes PROK2, CD7, WDR11, DUSP6. These genes are responsible for migration and development GnRH neurons. and genes GNRHR and GNRH1. 9 female patients diagnosed with idiopathic hypogonadotropic hypogonadism aged from 70 to 27 years participated in our study. Duration of the disease was from 1 to 30 years. 3 of our patients have primary amenorrhea and 6 have secondary amenorrhea. And reasons for secondary amenorrhea were stress, excessive physical exercises, rapid body weight loss, and past use of oral contraceptives. In the control group was included 19 healthy women aged from 19 to 37 with a normal menstrual regular cycle, and some of them have children. Results of our investigation were as follows. mRNA expression of examined genes differed from normal patterns of expression in each case of hypogonadotropic hypogonadism. The change of expression were most frequently in the case of genes GNRHR, GNRH1, and DUSP6. This graphics shows us expression profiles of patient in compare with the median expression of these genes in control group. As we can see, alterations of expression in the case of gene GNRHR are the most multidirectional. In the case of genes GNRH1 and DUSP6, was recognized a tendency to overexpression in patient group and compare with the control group. There were no any significant tendencies in the expression of genes PROK2, CHD7, and WDR11. So how we can see variations of expression of investigated genes differ, was very multidirectional in each case of hypogonadotropic hypogonadism. And we can't find any similarities between expression profiles of patients according to amenorrhea type or anamnestic factors. So to sum up, according to our preliminary results, we can say that functional activity impairment of reproductive responsible genes could be found in each case of hypogonadotropic hypogonadism. And this fact suggests that in future, maybe mRNA expression measuring can be a promising diagnostic method for the proving of hypothalamo-pituitary level of reproductive disorders, and maybe also can help to determine genes that should be tested for DNA failure. It's our team. Thank you for attention.
Okay, thank you. Are there any questions from the audience? Yes? Mariska.
Thank you for your presentation. And I was wondering, what is the time interval of the females who were using previously oral anticonceptives?
Time of using?
Yes, at the time of use, and also the time of their stopping before they were included in your study as being a control patient.
Time of use was from 1 year to 3 years, about this.
Okay. And do you think that you could explain a part of the effects you see of the results in your study to the time difference of the woman stopping the anti-conceptive therapy?
You mean the connection between using of oral contraceptives and amenorrhea, or?
Yes, like the relationship between that.
Our method shows that RNA expression was differed from the normal patterns. So I think we can say that it's connected.
Okay, thank you.
Okay.
Hello, very nice presentation. I have a question regarding the basics of the study maybe, but the genes that you analyzed are acting and expressed in hypothalamic pituitary level. That's their role. And you measure them in peripheral blood,
In
yes?
peripheral blood,
Are there
yes.
any data which support such analysis? Because I think that it can be two different stories. This is typical for the studies regarding hypothalamic level.
According to data, these genes can be found, mRNA of the genes can be found in the leukocytes of peripheral blood. And now our investigation is going, and now we are conducting experiments with the rats. We investigate the expression of these genes in the hypothalamus and in blood, and we found correlation.
Okay, that confirms. Thank you.
Thank you, very interesting data. Have you performed any genetic tests to look for some germline mutations in LH receptor genes or some other?
As I already said, our investigation is going, and now we are starting to seek for DNA impairment in these genes.
And have you had in any of your patients some suggesting phenotype, like clinical features, to suppose that some of them could have this kind of genetic predisposition?
Yes, we have at least one patient who have family anamnesis of this disorder, so we suggest that she may have genetic impairment.
Okay, so you are going to perform this kind of tests?
Sorry?
So you are going to perform
Yes,
this kind
yes,
of test
yes,
to check?
yes.
Okay.
Okay, I think if there's no other question, we should move on, because we have also the Lancet for the first. Thank you for a nice presentation.
Okay, so our next speaker is Monika Šramková from Czech Republic, and she's going to talk about physiological changes of adipokines during the menstrual cycle.
So, good afternoon. It's a pleasure for me to present here our study. That topic is a level of adipokines and some steroids during the menstrual cycle. For introduction, the cyclical effects of hormones are not just responsible for ovulation or influencing and control of ovulation, but they have significant effect on on energy intake and appetite. Many studies have described this influence. Very well documented is the influence of energy intake in thin women during the luteal phase of menstrual cycle. These relationships led to question how adipose tissue, the role of adipose tissue in this. So you know that adipokines are a protein-based group of agents produced by adipocytes. They have many physiological functions. They have influence on food intake, energy expenditure, development of cardiovascular risk. They have connections with immune system, and they affect hemocoagulation and function of the reproduction system. Up to now, we know about 40 adipokines that were identified, and they are intensively studied. The studies about the changes of adipokines during the menstrual cycle are inconsistent. Some studies describe changes, some increasing, but some found nothing, no changes. So the aim of our study was to describe changes and relationships between the menstrual cycle and selected hormones, steroids, adipokines, and some food intake related hormones. In our study were involved 27 women, thin women, and they have a normal length menstrual cycle. The fasting blood were taken from the first or second day of the menstrual cycle and between 7 to 8 a.m. And the subsequent samples were taken in the interval of 3 days. For all samples, we measured these steroid hormones. As you see, luteinizing hormone, follicle-stimulating hormone, sex hormone binding globulin, testosterone, ATC, and we used for this measurement radioimmunoassays and for adrenocorticotropic hormone electrochemiluminescence. Also, we have measured by using magnetic bead-based multiple assay from Luminex Corporation to measure these adipokines and food intake related hormones. So I chose only some graphs according to time of presentation. So we can see their profiles of changes during the menstrual cycle that were compared after synchronization.
Sorry, if you want to stay a little bit
far away.
From the mic, a little bit. A little bit far away from the microphone because it.
Okay.
Yeah,
Can you hear me?
Yeah, yeah.
So the profiles of all women were compared after synchronization of the day of the peak of LH hormone. So this day was set as the 0-day reference point. So we can see in this graph that gonadotropins and estradiol and progesterone had expected trends with increasing during the ovulation. Here we can see the profiles of testosterone, SHBG, 70-hydroxyprogesterone and cortisol. Cortisol had no significant decrease during the ovulation, and the increasing of levels of testosterone was followed by SHBG. So we know that the levels of free testosterone were higher than levels of was higher than total testosterone. Here we can see some adipokines. We didn't found changes during the menstrual cycle. Leptin has had some increasing during the ovulation, but it had no significant. And resistin and adipsin had showed a notable increase during the ovulation, but that was no statistical. And adiponectin was increased in at the start of cycle. So for conclusion, the cyclical changes in adipokines during the menstrual cycle are not particularly striking, but even so can play a role in the changes in food intake during the menstrual cycle. A further important question is the possibility of changes in steroid hormones during the menstrual cycle affecting adipokine receptors, which would also contribute to changes in food intake. In order to precisely discriminate between cyclical changes and pathological states, it's necessary to have a better understanding of the pathophysiology of these disorders and the role of both steroid hormones and adipokines in their development. Thank you for your attention.
Well, thank you very much. Are there any questions? No? Gipsy, do you have any comments?
I think I'm okay. This is really an interesting study because sometimes we think that menstrual cycle plays an important role, and it seems that it doesn't, and some other times we overlook at menstrual cycle, and it's always nice to have information and studies like that. We don't have a lot of data, you know, of baseline studies in
No.
no, we don't. And the data we know they are based on studies really
long
time ago.
Yes, that's true.
So thank you.
Thank you.
And thank you all for your kindness to be here and not to be in Moscow Center shopping and scrolling around. Now we have lunch, and early at afternoon you'll have time for sightseeing and scrolling around. So thank you all for being here.